we can start. I think we're being recorded, as always, to make this available to the public. And as you will all know, this is my first board meeting, so I'm hoping that I'll do all right. And just to cheer me up this morning, the very first message I opened on my phone was from Philip. And Philip wishing me, and it almost made me cry. I thought it was so sweet of him, so kind of him to think of me this morning. So obviously, you know, we're all massively grateful for everything Philip did for the trust. And you know, I know they're big shoes to fill, and I will do my absolute best to do that. So we've also got a few other different people here today, so it feels a little bit of changing of the guard on a number of fronts. So I'm just going to run through the people that have joined us this morning, and we've got Vicky Pickles, who many of you will know anyway, and she's joined us now as the Director of Corporate Affairs. We've got Lindsay, who's here for the first time as the Chief Nurse. We've got Cornell Parker, who is on her, I think, her last day, which is really good of you, standing in for David Birkenhead, who sent his apologies. So welcome, Cornell, and thank you and goodbye, all in one sentence. I think I've seen on Twitter that you've been having your leaving dues this week. And then we've got, I think, I'm just checking whether, do we have Emma Rhodes with us, who was from HR, who is observing us today. I can't see her yet. She may join us at some point, in which case we can welcome Emma. And Nicola has also joined us, who's our associate non-exec. And then from the public governors, I think we should have Peter, Bamber, Alison Schofield, who I can't see on my list, but hopefully she's, if not here yet, will be joining us at some point. Gina Choi, who I have seen, yeah, and a little wave there as well. Christine Mills, who is maybe due to join us but hasn't yet, as far as I can see. And I think we got apologies from John Gledhill, if I can remember that. So this is always a moving feast, isn't it? I get a nice little briefing, and then of course it all changes in the 24 hours prior to the meeting. Also want to welcome Holly and Helen, who are here for our public patient voice item. So hi to both of you. We'll try and get to you as quickly as we can this morning, so that you're not kept waiting too long. And then we've got apologies, as I mentioned, David. We've also got Tim Busby and Nigel Broadbent, who are the two new non-executive directors who have pre-commitments, as is often the case when people are appointed to new roles. And we've also got Rob Burkitt's, apologies, who is the Director of Digital now, since Jim left the organisation. So again, we would have welcomed him in his role as Director of Digital, but he too is on holiday. So I think, apart from the people who are expected to be here, I think I have covered everybody else that is either new or observing today. And if I have missed anybody, please just pop your hand up. No, Amber's giving me the thumbs up, so that'll do. So Amber and I will be communicating telepathically most of this morning, so she keeps me on track. The other thing I'm hoping is that this is the last board meeting that we do on Microsoft Teams. I really would like us to get in a room and to look at each other and see each other smiling and be able to have that normal interaction that you have in a room, because I think people have been missing that. So although I know at the moment it's in as a Microsoft Teams invite for the 1st of September, I do hope this is the last. I hope this is the last one, although you never know in terms of what's happening with COVID. I think from a public point of view, I have just checked this out this morning, although I don't think we proactively invite people to raise any questions with us when we publish our agenda. Again, had we been in a meeting room, that would have been sort of standard practice. So if anybody does happen to be watching this recording after the meeting and you would have liked to have raised a question on anything on the agenda, please, feel free to do so either directly with me or with Brendan. I'm sure we would be more than happy to think of this as a method of engagement, even though it is maybe not an ideal method of engagement. Okay, so in terms of the sort of etiquette of the meeting, I think most people are on silent. Put your hand up. I will try and keep an eye on who's putting their hand up. I can't always keep an eye on the chat and the hand up, so I'll do my best. But please just tell me if I've missed something. I'm more than happy to take instruction. So in terms of declarations of interest, if we move on to that, can anybody who has got an interest that they need to declare on any items of the agenda, could you please do so now? And if anything comes up during the course of the meeting for which you think you need to declare an interest, please pop it in the chat when we get to the item. Karen?
Yeah, I'd just like to declare an interest in item 20. I am mentioned in item 20, which is around the governance.
You are indeed. Okay, thank you. Duly noted. Okay, if we're all right to move on, I don't think that's an interest that requires us to send you out of the room. I think it's fine for you to stay unless anybody objects that you do so. Okay, so moving on to the minutes of the meeting that was held on the 5th of May. So I was in attendance at that meeting, so I don't feel completely outside of the picture, but I wasn't a formal member at that time. So I'm going to work on the assumption that you've read those minutes, and if there is anything that you would like to pick up in terms of any points of accuracy, I shall just very quickly run through them. And Richard, he was like fastest finger first there, wasn't he?
Look, I'd hate to disappoint you, Helen, in your first meeting.
I know.
Look, I did just have one point, and apologies, Anne, because I've read them once, so I must have missed this. So, do you want me to raise it now? My point of factual, it's just clarification, really. I think I'm looking at the top of page 5 of the minutes, and I think it's page 5 on convene, and it's where we're talking about the financial plan. And it talks about this is after delivery of 20 million of efficiency savings and 5 million of COVID costs. I mean, I think we know what we mean, but actually it's 5 million of COVID cost savings. Our COVID cost number will be different to that. I think it's about 3.5 million already in 2 months. But so just to be clear, I think it ought to say 5 million of COVID cost savings, unless Gary tells me differently.
No, he's nodding and thumbs up from Gary there. So if we can
that's
make
all I have, Helen.
Is that all? That's good. Okay, so did anybody else have any matters of accuracy on the minutes on any of the pages? No. So we'll take those with that amendment suggested by Richard as a correct record of our last meeting. And we can approve those minutes if people are content to do so. So that's great. Thank you. Now, matters arising. This is an interesting one. This when I was having my discussion about, said, well, where's the action log? I know there isn't one because they were all closed. And they were all closed at the last meeting. So probably the first meeting I've ever been on where there isn't an action log or isn't something in terms of actions that came out of the last meeting that would be picked up or not picked up on the agenda. And so, but there aren't, unless anybody has spotted anything in those minutes that they thought should have been actioned. We did go through them quite thoroughly yesterday just to make sure that hadn't happened. It did make me consider the active nature of a board that meets for a whole 4 hours and doesn't have anything to suggest needs to happen afterwards. So maybe we can, maybe that's something we can think about in our board development. And certainly in a number of the items today are to note. And again, I wonder whether or not some of these are more endorsements or than necessarily just noting, because it does feel a little passive. I would suggest for a board to just note everything. But if there's no actions, I'm not going to eke it out. Okay, so moving on to the chair's report. Obviously, I've not been here very long. I started last Friday, and in the sort of short time that I've been here, I've done the tours of the 2 hospital sites and also visited one of the community teams in Broad Street, just to get a sort of sense, a starting sense of the organisation. Brendan and I went to the development session of the Calderdale Cares Partnership Board last Friday afternoon. And the first meeting of that in public will be in July, but this was a development session, just really looking at how the meeting was going to be structured, how the agenda was going to work. And that coincided with also the launch of these new arrangements around the integrated care system. And it was also the first meeting of the Integrated Care Board last Friday morning. And if any of you got the opportunity to watch that, again, it was publicly broadcast. Much of that meeting was around the constitutional things that a new board has to do in terms of its standing orders, its governance handbooks, its decision making, its policies, lead roles for individuals, and the like. So I'm sure Kathy, the chair, wouldn't mind me saying it probably wasn't the most exciting of meetings in terms of direction and strategy and ambition, but nevertheless it's an essential meeting that was required to set the ICB off. I've also chaired my first organ donation committee meeting yesterday, which was interesting. Not an area I've been that familiar with, to be fair, but Vicky and I were both at that meeting, and it was we immediately started to think about how we could utilise some of the opportunities around promoting organ donation, but also on the back of the getting the trust more generally out into the thinking about it as another engagement tool. So that was good to do. And just to remind people, it's Organ Donation Week, the first week in September, which I think we may be able to do, maybe have a little bit of a mention of that at our next board meeting. And it is also the Transplant Games at the end of July. So again, if any of you are in Leeds, I think there's quite a lot of carrying on going on there around the Transplant Games, and maybe people that we know who are competing in those that we can give a little bit of a shout out to. So again, it would be good if we could try and promote that through any of our social media and the like, if that was possible. And the rest of my time I've spent talking to people, seeing how things work around here, and what sort of things they'd like to stay the same and what people would like to see change for the better if necessary. And I'm not one for changing things for the sake of it, but I'm certainly getting a sense from particularly some of people that have been around a while and people that have been here just a short time are starting to think of what I would call even better ifs. So I think we should encourage a bit of new thinking if we can, but let's take our time over it and do it. And so you'll see today's agenda will just follow the same pattern as all of your previous ones have followed, and if we make any changes, we'll do those through our development sessions, I think, and make sure everybody's on board and engaged with them. So that's been me so far. It's not bad, is it, for 6 days, really? I feel as though I've done something, and it's been great to be welcomed so much into the trust. So any questions on anything I've said? No? Okay, hand over to Brendan then for the Chief Exec's report.
Thanks, Helen. I think we should record a warm welcome to you as our chair. So it's good to have you with us, and clearly there's been a lot going on. We live in strange times. Clearly the world around us is changing. In and amongst that, I'm assured by the work that our colleagues continue to take forward. I might just start by building on one of your opening comments. I think at this point I should thank Cornell on behalf of the board for her past 4+ years as Deputy Medical Director, and indeed for stepping into the breach on several occasions for David, and indeed for covering today. So thanks, Cornell. We would want to formally record your work and support in the organisation and wish you well for your next venture. So good luck. I think probably I'll be brief. What I want to do is probably frame the conversation we're having today. So I've said the political environment we're all living in is pretty febrile, and there will be further changes, I suspect, over the course of the day. But in and amongst that, we're actually still living in a pandemic. And as you will all be aware, we have had to reintroduce some of the restrictions that had been lifted, certainly within the health setting, and Lindsay will talk through some of those measures in the agenda item today. Certainly our national leaders and our NHS leaders have been in conference and indeed setting the tone for the refresh of the NHS and social care strategy. There's been conversation about the 4 Rs, which I'm assured again speak to our agenda around recovery, reform, resilience and respect. And that respect is for the communities we serve, using the public pound wisely, for our patients within the recovery agenda, which is going to continue to be challenging, and indeed for our colleagues who go above and beyond every day, whether they are clinical or non-clinical, or whether they're working in our community or our hospital settings. We really do need to continue to support them and thank them for all that they're doing, and give them a sense of realistic optimism. This isn't about us not being in touch with what's happening at the coalface. We know how challenging it is, but we do need to give people hope for the future. And indeed, our colleagues continue to give us hope. So it's good to see. So I think the agenda today captures some of that. It mirrors where our national leaders are. In and amongst all this, Helen, as you said, statute has now landed and the integrated care system is now a legal entity. And again, I think we need to remember we are part of that integrated system. We are it. And as part of that, it isn't just about our acute offer, it's about our role as an anchor partner. We do need to pay attention, I think, to some of the challenges that are taking place in primary care. I think one of Amanda Pritchard's forward-thinking commentary was around the Fuller report on what that would mean for our GP colleagues going forward. We do need to think about how we work in partnership with them, and I think it speaks again to some of the leadership changes that we're proposing going forward. I think the other thing I would want to just say is we don't operate in normal times, and some of the challenges that we're facing are deeply entrenched and difficult to deal with. If they were easy, we would have dealt with them by now. But again, I think one of the things that have come from the pandemic is how do we truly revisit and embed a quality improvement methodology that isn't glib, that actually does get to the heart of some of the deeply rooted challenges that we see. And I do think we're in a fortunate position in West Yorkshire, and indeed as part of WIAT, the West Yorkshire Association of Acute Trusts, to take some of that work forward and look at some of the fragility of the services that we see and the fragility of some of our workforce problems. So I'm hopeful that without this being a standardised one-size-fits-all quality improvement initiative that probably some of us have seen before, there will be a different approach to how we tackle some of these initiatives. And Peter's on the call. Actually, Joe and I met with Peter about some of the conversations we need to have with our colleagues, because they have some of the solutions. It's how do we think about working together going forward. And in and amongst all of this, we're going to hear from some of our colleagues shortly, but I think it's important to continue to recognise the work that our colleagues have led on around the health inequalities agenda. I've seen a report today talking about platforms that are going to be used that may marginalise some of the white middle class. I'm not going to comment on that at this point. I think what we need to continue to do is think about the work we're doing for the communities we serve in Calderdale and Kirklees, and think about how we take that agenda forward, again in partnership with some of our primary care colleagues, and think about our digital strategy and how that truly could enable us to think very differently about the work that we're doing. I think credit to particularly Anna, Ellen and Peter, who have led on this on our behalves, but there's more that we want to do and more that we can do. And again, I think this speaks to Anna's refresh of our strategy and what truly our services could look like within the next 5 years. Actually, I'll probably circulate it after the meeting through to you, Amber, but Vicky and I have been in consultation with the national comms team around health inequalities, and you will see that we have been tweeting and very prominent on social media around our case study for the work that we've done. But as I said, I think it's important that we continue to build on that. So I'm assured that some of the national agenda frames some of our thinking. I do like the recovery, reform, resilience and respect analogies. I think that speaks to what we're keen to do. None of this is easy, but thanks to our colleagues, we continue to do what we need to do. Happy to take any questions at this point.
Any questions for Brendan? I do think it is a challenging time at the moment, and I think it is easy at this point to become very distracted by what's happening nationally and worried. I think a lot of people will be worried. We have to recognise that this can create quite a bit of anxiety in people when things are so subject to unrest. But you've got to hold the line, haven't you, and keep doing what's right. Okay, if there's no, Karen.
Yeah, could I just ask Brendan? The integrated care system is now here with us, and as you quite rightly say, we are part of that, and that's fine. How are we actually making sure our colleagues, our staff, understand and are aware of that?
So I think that's the $1 million question at a certain level, Karen. I think, how does this become part of everybody's day job, and how do we get our colleagues to feel that they're part of a bigger system without them losing their identity with CHFT? I don't want to speak for any of our clinical colleagues, but actually I think they're probably much more interested in what it feels like to work in a particular ward or department than to think about what it feels like to be part of West Yorkshire. But equally, there are some of our leadership and management teams who are chomping at the bit, actually, to be involved in some of the regional work and to influence how we do some of those things. And I think there are layers upon layers within all of this. So the work that we are doing alongside Mid Yorks around our non-surgical oncology and some of our community diagnostics speaks to the partnership working. There are other colleagues who are working much more at a West Yorkshire level. So for instance, around the pathology initiatives. And then there's our whole reconfiguration piece. I think there's just something about, for me, how do we ensure that people are engaged with and not engaged to on this agenda, and how we bring them with us on it. And then I
agree. I was just going to add that I think it's about it. You're right. It's about leaders and managers not relying on you and the other executives to identify opportunities, but also to identify the opportunities where that's realistic and feasible.
Yeah, I think we've got a seat at every table. I want to ensure we're truly represented, but it speaks to that leadership development piece I think you've described as well. How do we develop our leaders to be system thinkers? We need to enable them to do that. I think it's exciting, it's challenging. And again, I think the work Suzanne's leading on should help equip us to do that. Yeah, I think the other thing, Karen, I'll finish with this. We need to keep testing it out with our colleagues actually to see if we're getting it right for them.
Yeah. Okay, thank you.
It's all about added value, isn't it? If it adds value to the work that we're doing, then people engage with it. If it becomes something you have to just do and it doesn't add value, people quickly become disengaged. But similarly, we have great things that we're doing that we can add value to those wider conversations, and it's been able to do both. Can I just ask you one thing, Brenda, about the COVID public inquiry? If in terms of, because I know we're aware that that's sort of looming and our sort of readiness for that.
Yeah, so I think Andrea has led a significant piece of work on this and has got to a place where we're as ready as we are at this point within it. It feels, and I may use the wrong words in this, Helen, Andrea and Vicky may correct me, but it feels we've come to a pause. I think as the terms of reference have been confirmed, this will clearly grow. We're not actually pausing. I think we're continuing the work that we've been leading on, but probably much more in the background than at the forefront at this point. I think it will pick back up from the autumn. There are listening events planned, but we're waiting for further information about what that looks like. I do feel Andrew's got us to a good place with it all. We just need to stay in that space and stay ready. Andrew, does that cover it?
Yes, and we will be bringing something to the board hopefully in September, just to sort of give you an overview of the preparation that we've done now that the final terms of reference have been confirmed.
I think that the other thing we need to think about, Helen, is how we take that into the organisation and share that with colleagues.
Yeah, and presumably with the board, so we understand what our role and responsibility is around no doubt the many plethora of things that we are asked to do, what sort of level of oversight and things we have to provide to that, and how much is being directed to us.
Yeah,
Okay.
that'll be. I think the start of that will be September, but it will grow.
Yeah. Okay, so we look forward to having that come back on our agenda in September. Okay, so if we're all right with those updates, thank you very much, Brendan. As they say, we live in interesting times. And now we're going to move on to a discussion and a presentation from Holly and Helen that's really sounds very interesting about the work of the Macmillan Cancer Support Service. And I'm looking forward to the presentation that you're going to read, and I think you are going to upload something, so we might have one of those little awkward moments where we wait for all of that to happen.
Hopefully not. Hopefully not. I'm going to share it now, if that's okay with everybody. And good
Lovely.
morning. Nice to see you all.
Hi, Holly.
Oh, good morning, everybody. Thanks so much for inviting us today. We've been doing various presentations and really celebrating the success of our service and our team and the difference that we make to patients. So it's a real honour to be here sharing our story with you. I'm Helen Jones. I manage the Macmillan Information and Support Service, and Holly is one of my fabulous colleagues who is going to talk to you about a patient story. Could you go from the first slide, Holly?
Of course.
If you can go, can you make it a big screen? That's it, fabulous. So we're the Macmillan Information Support Service. We were originally funded by Macmillan from 2013. For a number of years, they paid for the main centre, which is at Calderdale Hospital, and funded staff over the years. But gradually, the trust has taken over that funding, and now all four of us are funded by CHFT. A lot of people don't know that we exist, so we're really trying to fly the flag and let people know that we're here. And actually what people have said in other presentations is that they're glad they know about us in case staff family members want to access our support. So that's been kind of an unexpected benefit of us doing these talks. So we have a drop-in centre both at Calderdale in the Macmillan unit and on the Greenley unit at HRI, and those are our contact details and a picture of our 4 staff. Next slide, Holly, please. So I'm just going to introduce the service, tell you a little bit about it. Holly's going to talk about a patient story, and then I'm just going to briefly tell you about our education programmes. But these are just a few of our key statistics for 2021 that we're really proud of. So last year we saw over 4,000 people, whether that includes phone calls, but we had contacts with over 4,000 people, which was a 27% increase from 2020. So during the pandemic, more and more people have accessed our service for emotional support, practical help and financial support. A lot of what we do is around money worries, supporting people who are unable to work and the finances are affected. And our referrals to our benefits team actually raised over £1,300,000 for local people in disability benefits that most of them were unaware they'd be able to claim. We got over £54,000 in Macmillan grants for our patients. We made 761 referrals to other organisations for support. So even though we've been very active, very busy, this is one statistic that does make me a little sad, and that's actually that we've only reached 25% of all newly diagnosed patients in the trust. So actually there's a huge number of people who perhaps don't know about us or who are not yet accessing our support. And that's partly why we're doing these presentations, to raise the profile and encourage those people who've not accessed us to come to us for their support. I think a key part of what we do is to reduce anxiety. So 79% of people said that we did reduce their anxiety, and nearly 20% didn't have any anxiety around the cancer. And importantly, what we do as a non-clinical support service is to reduce the pressure on our clinical colleagues. So we work really closely with our clinical teams, and actually the patients and the whole of those contacts have said 48% of them would have gone to their consultant or their clinical nurse specialist or their GP for this holistic support had they not come to us. So actually we save people time and money. Last year, we had nearly 500 attendances at our patient education programs and support groups. Probably our proudest statistic is that we did win a national Macmillan Excellence Award in November. That was called Whatever It Takes, and that was about recognising our service to people during the pandemic in particular. We were also finalists in the Patient Experience Network Awards, which were national awards. Unfortunately, we didn't win those despite being in 3 categories, but we were proud to get as far as we did. Next slide, Holly, please. So what do we actually do then? So we are obviously information centres. We provide information about lots of different aspects of life when people have a cancer diagnosis. So information about managing side effects, about work, finances, diet, exercise, talking to children about cancer, which is a popular booklet at the moment. We have a lot younger people that we're seeing, a lot more complex, advanced patients, many of whom have children. So we try to offer support to them. Travel insurance, lots of people come to us about asking for travel insurance information, and we can give information in other languages and formats. Emotional support is a really key part of what we offer. So we offer a listening ear service, and that's for patients and for family members. And actually the clinical teams often don't have that time, but we're really privileged to have that. We can sit with a patient or a family member and give them that chance to offload and share their worries and concerns. We run lots of different support groups and education sessions, all to help patients to learn how to manage themselves. And we do lots of signposting and referrals to other services such as counselling and psychology, hospices and bereavement support. Thanks, Holly. Financial support, I've already mentioned, is a big part of what we do. So we help people apply for benefits, Macmillan grants. We go to other charities. So I've had a patient this week who is in a very difficult family situation. We've just got him a holiday and a second grant for some spending money on that holiday because he said he couldn't even afford the petrol to get up to Filey, where he'd been gifted a caravan for a few days. We help with energy debts. We've helped to clear energy debts, which has meant actually people have been able to get their heating back on. So we just offer whatever support people might need. Practical help, we help apply for blue badges, which sounds a bit unimportant, but actually that makes a massive difference to people's quality of life. We issue things like toilet cards. We help with housing, liaise with the councils if people need to move, if they're in inappropriate housing. We have had a couple of homeless cancer patients who we've been able to get into accommodation as soon as we've had contact with them. We do lots of referrals for aids like stair lifts, bathroom adjustments, and actually we liaise with a lot of other people. So we liaise with schools. I'm currently liaising with a school at the moment about a patient who's 37 and has months to live. So I'm talking to the school about how to support their children, her children. We do a lot of work support, advocacy and information, lots of referral to other organisations, and we'll link with other professionals such as the GP and social care professionals, really to reduce the pressure on the patients to have to do that themselves. Okay, next slide. So I'm going to hand over to Holly now, and she's going to talk about how she supported a patient recently.
Hi everyone, my name's Holly Smith. I'm the support worker for the Macmillan Information and Support Service. So my patient story started about 4 months ago and is still ongoing. So this referral was made to us by a clinical nurse specialist, and this gentleman had been diagnosed with lymphoma actually after a cardiac arrest. As soon as I got this referral, I went up to the intensive care unit to support him, and his concerns was written to me because actually he was non-verbal at the time after having to have a tracheostomy fitted due to his cancer diagnosis. So his concerns were financial support, spirituality needs. He had no family support at home at all. He was actually the carer for his sibling, and still is, who is struggling with alcoholism. So he was really struggling to come to terms with everything, and was really actually affected by the cardiac arrest that he'd suffered more than his cancer diagnosis. And he actually was told that he had to start chemotherapy shortly after being admitted to the intensive care unit. So how we supported, as I said, he was seen on the day of the referral on the intensive care unit by myself. We communicated via written communication, and also body language was very important. We did a benefit referral on that day, and also a Macmillan grant, as Helen just mentioned, and that was awarded to him within 1 week. So he was awarded £465 to help with anything really. So that's for anything like clothing, heating costs, travel, anything at all, anything that he needed. He was also referred to our CHFT chaplaincy service, as that was one of his main concerns. And as he got stepped down from the intensive care unit, I followed him through to one of our other wards. Our contact details were provided. We communicated very much through the nurses. So I said to him, whenever you need me, whenever you want to talk to me, even if it's just a listening ear, you let the nurses know, and the nurses will let me know, as one of his problems was not being able to verbally communicate with me at the time. We supported with mortgage worries, because actually not long before his diagnosis and his cardiac arrest, his mother passed away. So he had her property and his own property to deal with. So we very much supported with his mortgage worries through the mortgage broker and himself. And actually, I wasn't able to communicate with his brother, as he requested me not to, due to his alcoholism. We also referred to the hospital social work team, and I very much, more than anything else, provided a listening ear and ongoing support, just somebody to talk to. Anything that he needed, I was there for. So overcoming the barriers were for him frustration, anger, fear for the future, anxiety, the psychological effects from his recovery from his cardiac arrest, the non-verbal communication with our service, but other healthcare professionals also within the trust, having no family to be able to speak to. So we overcame them over a period of time. So we found out what he enjoyed. He was actually a music teacher and an artist. So some days I just sat in his room and we just listened to music on YouTube. All of our information was offered. And as Helen will speak about just after this patient story, we do run lots of different courses here. And because of the pandemic, everything that we did before, we turned virtual via Microsoft Teams. So this gentleman unfortunately couldn't attend those virtual patient education sessions. So from what I felt he needed, we picked out little techniques, hints and tips that I felt would benefit him. And I compiled them all together in books, online, lots of different ways, and I managed to provide him that support as well. So that psychological support mainly. Lots of reassurance was offered. I kept him informed of everything. So all the conversations I had with other healthcare professionals, mortgage advisors, benefits advisors, my managers as well. So lots of healthcare professionals in our service and in the community as well. Lots of time was offered. Prioritization, so the prioritization of him, his needs, and also our other patients. Support when needed. So that was face to face and via text because of him being non-verbal. And liaising with others, for example, finding out how to communicate with emergency services and our Macmillan helpline. So there was lots of research involved in just taking that time to make sure that we met his needs. And that was all whilst receiving other referrals via telephone, email, face-to-face from our clinical nurse specialists, palliative care team, family, self-referrals, our centre phones at Calderdale and Huddersfield going off, work mobiles ringing with patient calls that are also a priority to us. Emails coming in from patients, nurses, consultants, community services, hospitals, family members, carers, friends, patient representatives, and our lovely volunteers as well. And also, whilst running our support groups virtually and face-to-face, patient education courses, again, virtually and face-to-face, community involvement in the ethnic minority communities, creating our monthly newsletters, which are now sent to over 1,120 patients within Calderdale and Kirklees, promoting our service and doing whatever it takes to deliver outstanding, compassionate care for our patients and their loved ones. And I will hand over to Helen again. Thank you very much.
Thanks, Holly. Really proud of you for all that you've
Thank
delivered
you.
there for that patient. Just very quickly, I'll just run through our education programmes, conscious of you having a 4-hour agenda, so I'll be brief. So we run 4 programmes. First Steps is something that we designed in our trust for people who were recently diagnosed. People told us they were given booklets that they couldn't face reading and they wanted a conversation. So we used to deliver it as a face-to-face session, and we put it online in the pandemic. It's actually been adapted by other trusts now. So Harrogate are starting to use First Steps and Mid Yorkshire. So it's great that actually there's been benefits to other trusts of our initiative. We run it on the first Monday of the month, and numbers are unfortunately quite disappointing, but it's a really helpful session about how people can support themselves in terms of keeping active, what to eat, managing their emotions, but also about support services that might be able to help them through the journey. Next slide, thank you. Thinking Ahead is our programme for people who have incurable cancer. It's for patients and families. It was originally devised in Harrogate in 2018, and we brought it into our trust in 2019. We actually run it collaboratively now with Harrogate and Leeds Trust as a virtual course, and we run that 3 times a year. It's really important because it introduces earlier conversations about advanced care planning and end of life. There's lots of information about support services, diet finance, mindfulness, a psychology session on managing uncertainty, estates planning, faith and spirituality. We've actually got some fabulous videos that we made last year of patients talking about the Thinking Ahead course. So I'd really encourage you, if you've got a few minutes, to Google CHFT Thinking Ahead and watch our 5-minute video where patients talk about the value of the Thinking Ahead programme. Again, so we're working collaboratively with the 3 trusts, but looking to work with the 6 trusts across the Alliance footprint to deliver Thinking Ahead, and we're essentially leading on that. Macmillan's I Hope programme is another course that we run. This is a national programme to really help people self-manage and to build resilience and manage the stress of cancer. It's a positive psychology course using mindfulness, gratitude, goal setting, peer support with loads of really helpful topics, communication, diet, exercise, even a session on sex and intimacy, which is a big issue for people affected by cancer, but one that nobody talks about. So it's great to give people the opportunity to delve into difficult topics as well. We've all had to be trained as facilitators, and we actually have a patient who's also a facilitator and runs the course with us, which is fabulous. And we've got 2 more patients who are hoping to train this year. Interestingly, I Hope is actually being delivered nationally as a psychology intervention through IAPT services. So again, that's great that we're able to deliver that within our trust for our patients. And we run that 3 times a year, and it's our most popular and well attended course. The last one is we also run an end of treatment event. So this is for people who have a curative diagnosis to help them to move forward after cancer. A lot of people talk about falling off the cliff when that hospital contact ends. So this is a way to help them have strategies to cope with life, to manage side effects, and to maintain as healthy a lifestyle as possible to reduce the risk of cancer coming back. So it's a lot of lifestyle sessions, physical activity, diet, etc., but also chance to meet with the clinical teams to ask any questions and raise concerns. Again, it's quite low uptake, so we're hoping that when we go back to face, we might get some more people involved. Next slide. Thank you. And then just lastly, various support groups. We run a virtual coffee group, a monthly Macmillan Health walk around Greenhead Park, a new men's cancer support group, and a body matters group, which is to look at issues around sex, body image, menopause, etc. And that's during and after cancer. And that's really come about, as has the men's cancer support group, because of patient request and patient feedback. And I think that's the end of our presentation. I hope we've not taken up too much of your time, but just to say I'm really proud of the team, and it's great to be able to be here today and just share some of that success with you. And thank you, Holly, for sharing your patient story today.
More than welcome.
Thank you both.
Thank you very much.
Despite this being a very challenging area, you're both very upbeat and full of energy, and I can imagine what a massive difference you must make just in your one-to-one interactions with people who are you know, have cancer and are experiencing some of the things you've described. And what you described there is a truly holistic and compassionate service. It just you know, I guess, you know, I'm going to ask people if they want to ask you any questions, but I would one thing that this trust could do to support better access, you know, you mentioned a couple of times you wish there were more, you know, only 25% of referrals, etc. What's one wish you would like to leave us with before you know, in terms of one thing we could do better to help get better access to?
I think I've said to Brendan that actually I'd love to access for the 75% who don't access us to know about us. They may not want to come to us, they may not need our support, and indeed a lot of skin cancer patients don't even identify themselves as cancer patients, but there's still a big chunk of people who don't know about us. So I'd just like them to know that we're here, and for us to have contact with the missing group that haven't had any support from us.
I think that's similar to Helen as well. We just want to be out there. We want everybody to use our service, you know, patients who have been diagnosed with cancer, but also the loved ones as well. And I think it's getting out into the communities. Obviously, as Brendan said, we're in a really tough time at the moment, and we're just eager to get out into the community also.
A very positive endorsement in our chat, including one immediate referral from Nicola to a family member who clearly was identified a need and a signposting straight away. So let's take a few questions from people. So I think I've got Karen, and then Joe, then Brendan. And I don't know if you're in the right order. I've switched you around there, but anyway.
Okay, well, mine's not a question. I just want to thank you. I think it's an absolutely great service, and I know a few people who have accessed your service, and whilst they haven't accessed the financial side, it's that emotional, spiritual side that they need, and they've had great benefit from knowing that, you know, it's a journey that they're not on their own with, even though they've got family and friends around them. It's someone who doesn't know them that they can perhaps talk a little bit more openly about. So I think it's a great service, and anything we can do to support and promote that, you know, we should do, and long may it continue.
Thank
Thank
you.
you.
Joe?
Thanks, Helen and Holly. I just want to offer a hand in the support. So I run a Wednesday brief to all the senior leaders in the organisation. I'd like you to come along to that and do your presentation. Also run a cancer delivery group where all the clinicians come. So we can definitely get into that and promoting the service and making sure that we get that message out for all our clinicians, and who can then offer that to our patients. So please get in touch with me outside of here. But great presentation, thank you.
Oh,
Thank you,
Joe.
Jo.
We'd be really happy to, come to both of those. So thank you.
Great.
That's great. And Brendan?
Holly, Helen, great. You're phenomenal on. You really are. So great that you've shared this. Helen, to your point, we've linked colleagues in with public health. This team are, and I mean this in a very positive way, victims of their own success. So they're incredibly busy. They're stretched. It's going to keep growing. As this grows and we get to the 75%, it's how do we resource them appropriately and enable them to still do what they do so well. There's something about how we share it speaks to the ICB conversation I would have thought, how do we share this resource, but indeed make sure that the team are supported so that they don't fall over in still delivering the platinum service that I think you're delivering.
Yeah, thank you. Happy
Thank
to,
you.
yeah, talk about that further, or any support you can give us. Yeah,
Yeah,
thank
so
you.
there's some practicalities around sort of expanding that reach, aren't they? That you know, need to be thought through properly. And I think you've got an immediate offer from Jo to join the sort of her weekly delivery conversation, so that at least that ask of being able to make sure people know that then they can share that information with the people they're seeing. I think well, it is at least it was worth you coming this morning to get that invitation, I think.
It was great. Thank you.
All right, so if there's nothing else from anybody else, thank you again very, very much. I think superb, you know, superb service that you offer. And as Brendan says, you could become victims of your own success if we don't think about this more broadly in some of those more strategic conversations as well. So thank you.
Thank you both. Thank you, everybody.
You're more than welcome to stay if you wanted to, but equally you may have better things to do with your morning.
Yeah. Thanks, everybody.
Thank
Have a
you,
good
everyone.
morning.
Take care.
Thank you. Bye.
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 Okay, so that was got us into a good feel mood, didn't it? That one, that's absolutely superb. So we're going to move on now to some of the substantive items on our agenda, starting off with our health inequalities update. And you should have a couple of papers around this. And I believe Anna is going to take us through the update.
I will.
Oh,
Thank you very much, Helen. So the report that's been included with the papers provides our regular update on the progress that we're making to help support a reduction in health inequalities experienced by people living in Calderdale and Kirklees. And as the board knows, we have an established Health Inequalities Committee, which is chaired by Peter, and has been taking forward this work against 4 key areas of focus. Those areas of focus are how we can work in new ways and improve ways with our local partners and our local communities to reduce inequalities, how we can make tangible difference in the lived experience of how people experience our services when they need them, and a particular focus around maternity services, the work that we've been taking forward to reduce inequalities in access to treatments and care, in addressing our waiting lists and backlogs of care. And then importantly, how we do this in a way that supports a diverse and inclusive workforce. So the report is structured against those 4 key areas, and it demonstrates that we are continuing to make good progress. And as Brendan highlighted in his update, some of the work that we've been doing in the Trust over the last 18 months has attracted attention as being leading the development of new ways of working. We're not in any way complacent. We know there's much more to do, but as we've said, we do have some profile at a national level through national conference and communication, but we're very keen to learn from other organisations as well, and importantly, learning from our local communities about what more we can do. I'm not going to go through all the detail that's in the report. I'm going to take it that people will have read the report, but I did want to highlight that this particular progress report does provide a detailed update around how we're reducing inequalities in access and waiting times. And what you will note in that is if we look back to May 2021, we knew then, or our data was showing us, that for people from Black, Asian, minority, ethnic communities and people living in the most deprived areas, they could be waiting between 5 to 8 weeks longer than other people to access the treatment they needed. And this is for people with the same level of clinical need, but just a differential waiting time. We identified that differential wait, and I'm very pleased that the report is confirming that what we can now show is that we have either closed or significantly narrowed that gap down to just 2 weeks at its worst, but in some cases there are no differential waits in some of those priority clinical grouping areas. So that's a big important step forward. What we want to do is to continue to ensure that that's sustained and that we further narrow the gaps where that is still in place. So overall, I think the report highlights some really good progress. We are, as a trust, we've developed, as we said, a plan on a page and 4 key areas of focus. We want to refresh that. So currently I have the benefit of a public health registrar working with the trust, who is working with the Health Inequalities Committee for us to refresh that strategy that will really highlight the key actions for us moving forward, building on this firm foundation. So I'll stop there. Happy to take questions. And I know many colleagues across the board are involved in this work and may want to contribute. Depending upon the questions raised, Helen. Thank you.
Okay, thank you very much. So I've got a couple of hands up from colleagues in terms of presumably questions for you. So I'll go with Richard first.
Thanks, Helen. And yeah, just to say, I think this report just demonstrates the progress that we have made, and you described it as good. I think it's probably better than that, but in terms of what we've done over the last year or so, we've got some great data. I think we're ahead of a lot of other trusts in this area, and certainly the progress that we've made around waiting times for the P2s, P3s, etc. is significant, and we can clearly demonstrate that progress. That's not to say we can't do more, obviously. I just want to, and it's a slightly negative point, I guess, from my point of view. I did raise last time at the meeting the point around mental health, and it is one of the key action areas listed. There was some discussion last time from Ellen about the role of a mental health nurse consultant, etc. When I read this report again, there isn't much reference to mental health. There's a very obtuse one, I think. So I'd just ask that going forward, maybe we could pick up on that one and give it a little bit more high profile. I fully accept it. I know Peter's told me a number of times before, there's a limit to what can be done in it's such a huge agenda, isn't it? But it is one of the key actions. We do say that we're addressing all these key actions. I just couldn't see a great deal in that area. So I would ask that maybe it just gets a bit more focus going forward.
Do you want to respond to that, Anna?
I think it's a good point. Thank you for the broader comments, Richard. But yes, it's a good point that you raised. There is less emphasis in this progress report around the work that we're doing to address inequalities relevant to mental health. I know there is a number of examples of work that we're undertaking, so I think we'll take that and make sure that that plays into the work both through the committee but into the next update to the board, highlights that and brings that to life.
So it's more about the work isn't getting reflected in the report rather than there isn't any work.
That's my understanding. Yeah. Yes.
Yeah. Okay. So I guess we can just presumably we take this update every time we would meet, and so we can action that in terms of making sure that work is therefore reflected in your report. Thank you. Andy?
Just echo Richard's comments. I think it's great to see the progress, especially the waiting list one. I think is really good to see. And the second positive for me, I think, Anna, is I really like some of the examples, very specific things. It could be easy in this to be quite general. So I don't know, be it asylum seekers, whatever external environment, that there's some very tangible things we're doing and trying, which is great to see. Going forward, I would have asked, but you've kind of headed it off already. We're making good progress on things. So what's next? So I think you're right. Refreshing the strategy feels spot on. And my last comment would be, as I kind of personally get a bit more engaged in voluntary sector in the local community, particularly the homeless sector, I'm sure there's more we can do in that. I mean, they're difficult people to reach. We do some things already in that environment. I suspect there's more we can do, certainly from having dealt with the Gathering Place and as one site, for example, where we do provide a service. I think there's more we could be doing for some of our harder to reach people in communities. And I'm going to kind of attack that from the voluntary sector and speak to some of the nurses I've met just about what the homeless sector thinks.
Okay, Anna, anything to come back on that point?
Again, I think these are points that all speak to the refresh of the strategy, the emphasis we place in that, making sure it's balanced, reflecting both the mental health, but also, you know, part of working with external partners, importantly, what work are we doing with voluntary sector and bringing that to life in the refresh strategy. So I think they're all things, I'm afraid to say, Helen, there are a bit of note in them, but I think they're work that we need to take the comments, build them into the refresh and come back on.
Yeah. Okay, thanks. Karen?
Yeah, just a couple of questions from me, Anna. In terms of, there's quite a lot of work going on with partner organisations. We obviously, this has to be joined up. We can't do this on our own. So my first question was, are we getting traction from partner organisations? Are they genuinely inputting into this process? It's fine as leading it, but we do want help and support and traction with partner organisations. And my second question was around the cultural awareness training, which is great. I'm glad to see that's something that we're offering. It's focused on maternity colleagues. I understand that and why that might be, but wasn't sure why it wasn't essential and wasn't sure why it wasn't offered on a wider basis to across the workforce.
If I may, just to respond to those, Karen, if I respond to the point around the partner organisations, but I might invite Suzanne just to respond around the cultural awareness training and why that's not essential, that and the second point. So on the first point, I think absolutely yes, there's really good traction with partner organisation. I think, you know, health inequalities has always been important, but I think the last experience, you know, during the pandemic, it's really highlighted the massive health inequalities in our communities, and all of our partners have this as high priority. And you know, for example, we've reported in previous progress reports, we've done some very joined up work in Calderdale around working with local on the BAME action plan in response to learning from the pandemic. Clearly, we're doing partnership working around the asylum seeker work, and we work with organisations. We're working with primary care in Kirklees. And, you know, just later on, I think it's later this week, each of our local place-based news subcommittees have health inequalities as top priority for their forward programme of work. And they're interested in the work that we've done. They recognise some of the areas where we are a little bit further ahead around some of that access work and around some of that partnership work to build on. So I think I could give an absolute firm yes, we are getting traction. It's not difficult to get people engaged. People actively want to be involved and delivering on this work. So yes, and if I would invite Suzanne to respond on the second point around the cultural awareness training.
Thank you, Anna.
Thanks, Anna. Thanks, Karen, for the question. It's a really good point. So we've recently developed that cultural awareness training, and there was a specific interest from colleagues in maternity services, and we're doing quite a lot of work with colleagues in maternity services at the moment, especially around Ockenden, as you know, and preparing them for that. So it's piloting in maternity. It does form part of our leadership programme, so it's going to be something that all our 400 managers will do, and we are refreshing our essential safety training. So we've got a growing number of essential safety training elements at the moment, and we're just looking at whether it's possible for colleagues to do all of them, both as core subjects and role specific. It's my hope that it does become an essential training item for everyone, but we're just working out how we do that.
Okay, thank you. Thank you.
And Denise.
Anna, thank you for really encouraging and positive report that, you know, shows great progress. I think that my question, part of it's already been asked by colleagues, and again it's around the working with our communities, and I'm just you know, you've made a statement around the fact that working with schools, GP practices and families to try and reduce the need for attendance for urgent and emergency attendances, and I just was really just wanting to query, and I'm sure this has already been done but wasn't explicit in the report, that opportunities are being used with the voluntary organisations, particularly community centres and faith centres, because they have a large role. They play a large role in the communities, and I'm wondering if you know, they've been tapped into as a resource to help this particular agenda.
So in terms of that work, and the area where you're referencing is the work that we're doing around with primary care partners around where there is an inequality in people needing to come into accident and emergency departments, which could be associated with if there was earlier support from a wide range of organisations in the community, may mean that was not necessary. So that is actively, as it says in the report, involving schools, looking at around housing, working with the GP partners. And in terms of the dialogue with local voluntary and faith organisations, the answer to that is we have reached out to faith organisations and with voluntary sector organisations, but I think it's a valid point that we need to bring more emphasis on that and more specificity about that piece of work, Denise. So it's a great point, because there's a really, as you say, a really important role for us to that. In other areas, the work that was undertaken around the response to the pandemic in Calderdale, that did work very much with local faith leaders and mosque leaders throughout that period, around listening to local communities, around how we engage with local communities, very much that dialogue through those faith communities.
Thanks, Anna.
Peter?
Helen, thank you. I'm conscious of time, obviously. I just wanted to say as a comment rather than a question, that I chair the group, and there is a real, I think it's worth saying, a real energy and a real enthusiasm around the group, around the table, and wanting to do more moving forward. I think the strategy, I'm really looking forward to seeing that come forward in the coming weeks and month or so, certainly in terms of stretching ourselves in terms of where we might go next. But I do think it's important that we don't try and jump over too many fences at once. And I know that plays back to Richard's point a few minutes ago, but yeah, it'd be good to see that stretched in terms of what we do next. But really positive from my point of view, Helen, in terms of the monthly meetings that we have.
That's great. And finally, Brendan.
Thanks, Helen. I'll be brief. I think Anna and Peter have probably responded to it, but to Denise's point, there's more to do, but there always will be. And there's a significant breadth to what we do. I think Lindsay and I meet regularly with some of our faith leaders. We've picked up a conversation with the Chancellor of the College, because there's something about young people in all of this, and indeed accessing his links to the local Sikh community. So I think it's multifactorial. I think it speaks to one of Vicky's objectives about how we brand ourselves as a partner organisation and how we promote the work of the Trust. But there's something about probably a bit of a stakeholder map in all of this, because this will be happening at different degrees. And I'd imagine, Denise, there's also something about our colleagues doing this without even badging it under this agenda. They'll just be getting on with it, notwithstanding the gap I think you've called out.
Okay, so I guess some of my questions and comments had been picked up there. I think the only bit remaining for me, Anna, is about the inequality that is experienced before people ever get into our services. So, you know, and I'm not talking about the broader inequalities of education and poverty. I'm talking about the access to treatment, the fewer referrals, the fewer conversions into treatment. So people that never get on the waiting list. We may treat people in a particular way when they're on the waiting list, but some people never get on there. And I'm guessing, and this may be something you can talk to me about, that as the work sort of developed across the partnerships in Calderdale and Kirklees, we will be able to, at this board, have a broader view of what's happening out with the walls of the hospital, as well as how we're complementing that with the work that happens within the services. So, and as those place-based partnerships become much more, I guess, you know, much more part of us and us part of them, that actually we could bring some of those broader reports to supplement what we're reporting here, because we'll no doubt be getting the Calderdale Cares Partnership Board minutes on our agendas at some point, and it may be that we can, that we can draw some of that into our conversations, and the things that people are referencing here about, what's happening in, say, mental health, what's happening in sort of primary care networks, etc. We could start and get a bit of a lens and a view on that.
If I may respond to that, Helen,
Yeah.
yes, absolutely. Addressing and reducing health inequalities for our local communities has to be a partnership approach, and it's not one organisation's agenda. They need to be connected, and we'll amplify each other's impacts, won't we, by doing that together. So I think, yes, absolutely, to bring that more rounded flavour around the overall nature of work going on in local places, not just each individual organisation. What I would reference, Helen, is there are some examples of work currently going on around some of that place-based working and for people prior to accessing services. So you may, I'll give an example. You may know that there's been some national studies done which shows that there is an inequality in people accessing hip replacement surgery. Which could be multiple reasons why people choose not to go forward and come in for treatment, which could be to do with inequalities of not having support at home, or being able to take time off work, or a range of issues. There is some work that we're currently doing, which is joined up with Huddersfield University, and particularly in Calderdale Place, around engaging with people about reasons why they may not come forward. And about what support might we do, and the aim is that in particular this might then lead to action specifically with some local voluntary organisations about how we can better support both people's knowledge and awareness of treatments they could access, but also support they may need, for the time when you have a hip replacement. It could be a deterrent that you don't have an infrastructure at home to be able to support you when you come out of hospital. So there are, again, pockets and examples of that work, and we do need to bring them and can bring them together more holistically in a more rounded report in the future.
Great, thank you. Nicola, sorry, I just spotted your hand.
It's okay. It's just to build on that point, really, to say that although this work stream is taking place as a standalone work stream within the trust, it's just to say that I think all of our different diverse areas that the NEDs look at, I feel that we're looking at it as well in part of those work streams. So just as an example, in the end of life care domain area and also the patient experience group, within our agendas, we're trying to reflect that health inequalities piece all the time, and it is a work in progress. But just as an example, we're trying to bring in demographics so we can be more representative of our populations and bring in diverse kind of areas of the agenda to reflect different discrete programs of work that are going on to target specific populations that we're working with. So I suppose it's just to say, as well as it being a standalone piece, we're trying to embed it across all of the work streams that we're working on, and that is a work in progress, and I'd welcome supporting this work stream. Absolutely.
Okay, so we draw this item to a close. We've obviously been asked to note the progress. I think we've, out of the conversation, we've I think real recognition from people about the work that's been done and the quality of work that's been done. If the report could include perhaps some of the things that people have asked for around sort of the work we're doing around mental health, maybe reflect some of the partnerships. And I don't think it's not about creating you loads of extra work, Anna. I think, feel free to, attach reports from other places just to give that enhanced sort of view of particularly the partnership work. And I think the final point from Nicola there is that that's the ultimate, isn't it? We don't have a separate report on inequalities because it's thoroughly embedded through everything that we do. Sadly, we're not there yet. But again, maybe reflecting that actually that is happening in some parts of in some of those other conversations where it's really at the forefront. So thank you very much. Your hand went up again. Was it a last minute thing or did you just click it by mistake? No, that's all right then. Okay, so I won't apologise for letting that item run a little bit, because I think it is pretty much top of the office when it comes to priority areas is inequalities for our population. And I think it's important that we're all very clearly sighted on the work we're doing and the work we still need to do. And we probably started to stray a little bit as well into the next item, which is also Anna's, which is around our annual strategic plan and our progress report. So we'll move seamlessly into that one, and then you can have a little rest.
Thank you very much, Helen. So this report provides our quarterly update of progress against our annual strategic plan. It provides a narrative update against each of the 19 key deliverables or objectives that are the actions we have agreed to take forward during this period up until March 2023. These actions are all work that we want to take place during this period that is in support of our longer term current 10-year strategy. Each objective, as I say, has a narrative descriptor of progress that has been made, but each one is also RAG rated. And what you will see in the report is that of the 19 key objectives or deliverables, we have one that is rated blue, which means it's been completed and closed. We have 17, so the vast majority that are rated green as on track and making good progress. And we have one that is amber, which does relate to our previous conversation, because the one that is amber is around work that is ongoing around how we use population health data to reduce inequalities. So as we've just discussed, we're making great strides in that regard, but we have RAG rated that as amber as we recognise there is much more to do to sustain and embed that approach. As requested at a previous board meeting, this report does now include within it a description of the key outcome each objective should enable. So I hope that's helpful to board members. It was a specific request that came from members of the board last time we reviewed progress. So I'll stop there. Again, happy to take questions.
Okay, so thank you for that update and the clear and comprehensive report. Andy.
So Anna, yeah, thank you for the outcome measures. It was me that was kind of, you may recollect, challenging. Can we have some outcome measures so we know it's successful? So good to see them. I guess I would just have a further push on some of these, is that they say improved this, the improved score. Do we have targets in mind, in which case we should set them, or are we literally saying just as long as it gets better, that's success? And then there are others where, I mean, some are clear, where, for example, I think it was, let me just find it here, give me a second. Emergency care, for example, you know, achieve metrics, achieve key performance metrics for urgent and emergency care and elective recovery. I know, Joe, you'll be talking about recovery shortly, and there's some very clear targets, aren't there, about dates on 104 and 78 and so on, so they're very clear. But for example, are we saying on urgent emergency care, we're going to achieve 95% given where we are? You know, what are we trying to do? So I guess my further challenge just would be, Anna, on some of these. Are we just improving, or do we have a target? And I would suggest it's the clearer it is, the better. But good progress overall. Good to see the progress we've already made. Thank you.
I think some of that speaks a little bit as well, doesn't it, to this sort of, is this our strategy, or is it our strategy to deliver others objectives, i.e. national policy objectives, you know? And I do think some of the just early conversations I've had, I think with board members, both executive and non-exec, would welcome a bit of a, probably a you know, a board development session around our strategy, our sort of direction, our ambition, so that the plan then can sort of demonstrate, I guess, and feed into sort of not just what we're expected to deliver, which I think often is where things like the emergency standard comes in, but what we would want to deliver in terms of further benefits and outcomes for our population. So I think there is a bit of a point, I guess, with a bit of new chief exec coming in, some changes around exec and non-exec, so to have a bit of a stop and think, I guess, about our strategy and what we're seeking to achieve through it, which I guess you would welcome at this point as well. And I think we can pick up things like the point Andy makes around, you know, what do we want, what do we want for our organisation and our population. Gary.
Yeah, thank you. There's just one item I just want to bring to the board's attention in terms of the performance measure around use of resources. So I have tried to clarify in the narrative this time, but just a reminder for everybody, there are two elements to the use of resource score. So when we talk about the general use of resource, it's generally something that comes about following a CQC assessment, a new well-led assessment. But in addition to that, there is also the finance use of resource score. And whilst we continue to demonstrate against the general use of resource score improvement, which is why I've scored as green as and on track, just a reminder that because we've changed the finance regime this year and we have now set a deficit plan, our finance use of resource score will deteriorate this year. But that is just one element of the overall use of resource score. So I've still considered that we're green and on track because I think we're doing the right things, and we will, you know, as per the metric in the score above, we're aiming to deliver the regulator approved plan. But just really to bring to everybody's attention, if we deliver the plan this year, our finance element of the use of resource score will deteriorate.
Okay, thank you. So we will note that in just in the narrative of our minutes today. Anna, do you want to come back?
I was just going to comment on the point you raised, Helen, regarding our refresh of strategy as the trust board. You know, taking that opportunity, which we've started with some workshop discussions, but to during this period up until March 2023, really to reframe our longer term strategy, which will then lead us to reframe the annual plan for April 2023 going forwards. And some of the specificity that Andy's referred to, we can assure then is absolutely targeted around that reframed what's important that we deliver as agreed by the board. So I think that's a piece of work in train, isn't it, in dialogue.
So from my sort of, I guess, reading of the report and the discussion is that we're pretty much on track to deliver most of our strategic objectives, with the exception of inequalities, which we've just spent quite a lot of time talking about some of the challenges within there. So that's sort of that reflects that. I think welcome the outcome measures, and that's obviously been asked for in previous discussions. And I think yeah, there's always you can always have a slightly sharper definition for some of those. It's like improve is like the word ongoing, isn't it? You know, it never quite sort of captures the work that's being done. So is there any other further questions? No. Okay. So with that, we will note the progress and recognise the changes that have been made to the progress report. So thank you very much. Okay, I shall move on. Might do one more item and then have a little comfort break, if that's okay. So if any of you are wriggling about a bit, you can try and hang on for one more item, and then we'll have that comfort break. So I think we're now moving on to the recovery update from Joe, and we received last night, hopefully in your convene system, which I'm just learning to get to grips with, you should have received a presentation that was uploaded last night. So hopefully everybody got that paper. Joe.
Thank you, Chair. I wasn't intending on going through it in detail, conscious of time. Just want to note some key points. So just on the first slide, Amber, the 104-week trajectory, by the end of June, we had one patient that we declared as waiting over 104 weeks. That patient will be treated in July. That was because the patient had become unwell. And to note, the patient had previous to come in dates that had been cancelled. So we've declared that 10 HSI, and we now continue to work through the 78-week plan to have 0 waits by the end of March 2023. Our internal trajectory for that is to achieve that by February 2023. And we're currently on track with that metric. 52 weeks, we aim to substantially reduce. Please note the trajectory to get to 0 by March 2023 is our internal stretch. So we're trying to really push ourselves That is not the trajectory that has been set nationally, but we are trying to push ourselves even further. ASI's appointment slot issues, as that is known, we continue to reduce these, but there is a substantial volume of patients, as you can see, in the total number and the patients over 22 weeks. What I will say is that we are receiving substantial report from our system partners and how we get those patients treated within the system. So we continue to monitor that. I'm not worried about that at the moment. We're still continuing to make really good progress. And the holding list is our follow-up patients and incomplete patients, and we're working through a plan to continue to reduce those. More focused work will continue to be implemented at the end of this month. I'd just also like to note the MRI trajectory in the report. We continue to reduce the backlog in MRI, but just like the board to note that we were 8.2 weeks on average for a wait for MRI scan. It's now 4.7 weeks. And we continue to work through our backlog with extra capacity ongoing in MRI, which is because of continuing demand, particularly in the cancer pathways. We have the new scanners at CRH, which are now up and running, so that's a point to celebrate. But to note, we do have continuing problems with the scanners at HRI. Those were the key things I wanted to note. I'm obviously happy to take any questions on the report.
Okay, thank you very much for that, Jo. And I guess that was my question when I'm looking at the report is, is there anything we should be really concerned about and anything we should be doing differently in order to expedite our recovery position? And I guess from what you're saying is, what I'm hearing you saying is we're doing everything that is reasonably possible at this point in time to achieve the best outcome we can in terms of our recovery. If I've got that wrong and I've misunderstood that, then correct me, but that's what I'm hearing from you in terms of assurance.
Yeah, no, I'm really happy with the progress that we've made.
Yeah, thank you. Karen.
Yeah, I was going to ask this and raise this question on the under finance, but as it links to this anyway, and so it might be something for Gary. I noticed in the finance report that clearly, being behind the curve with the elective recovery programme does have a funding implication. And I just wanted to ask the question, are we confident we can pull this back so we're not in a losing any funding at the end of the year?
I'll start. Gary might want to come in. So I think just to note that the plan was for surgery to get back into the full bed base in April. We couldn't do that because of the volume of COVID patients and emergency work that was in the hospital at the time. Surgery did not get full capacity until the 3rd week in May. They're now into their elective ward and have been working fully in their elective ward, but to note, they're not up to full capacity in theatres, which we've talked about previously. And we continue to experience some problems in running the theatre list that we've got due to some increase in staff absence around COVID and other issues that you would expect operationally. So, I have a level of confidence, but the situation around COVID and ongoing other issues, we have to note those risks.
Yeah. Okay.
Gary, can I just bring you in here in terms of that risk, and you may also wish to reflect on the debate that is happening today, I believe, around that elective recovery fund and the likelihood of that, because I've seen there's quite a lot on the Twitter sphere about that.
There is, yes. So Karen's right. In terms of our overall plan, we have assumed that there's just short of £12 million worth of funding that we'd receive in terms of the elective recovery fund, and that's by us delivering broadly 104% of what we were delivering a couple of years ago. At month 2, we're not at that level, and therefore at month 2 we hadn't assumed receipt of any of that elective recovery funding, which was probably worth about £1.4 million. In terms of the activity position, broadly speaking, at month 2, outpatients really positive position, but as Joe's just mentioned, still some challenges really in a number of specialties, but particularly around elective, and that links back to bed base and theatres and so on, as she's just mentioned. As Helen's just mentioned, there are lots of things happening, lots of discussions happening, and probably just some useful context across partners across West Yorkshire as well. So at the end of month 2 and even at the end of month 3, nobody's delivering against this at this point in time. So there are some discussions taking place about how we consistently report that the elective recovery fund. And there is still a lack of clarity about what happens if you don't earn it anyway. So if you don't earn the money, theoretically, the money goes back to the ICS. And what would the ICS do with it? Well, the ICS is likely to give it back to you in some other form. So as Helen's mentioned on Twitter and in other various documentations, it feels like they are considering rewriting some of the rules around ERF. And indeed, from a conversation that I've had with Brendan at 8 o'clock this morning and the position now as at 10:30, things have changed in terms of what we're expected to do at month 3. Either way, the right thing for us to do as an organisation is to try and make sure that we deliver that care to our patients. So we are going to do everything we can do to make sure that we deliver maximum amount of care, maximum amount of activity, and what comes through in terms of ERF will be what it'll be. To some extent, at this stage, we continue to assume that that full £12 million will come in.
I think that's a very wise position, isn't it? Because you can't control what you can't control, and you keep focused on doing the right thing in the right way, and manage the risk in case things don't pan out. But in my experience, when everybody's struggling, they change the rules. That's always what happens. Then it never materialises. But it's always a risk that you run with. Andy.
Just a very quick follow-up to that, Gary. So previously when we've had some of these funding regimes, they've been staged through the year, haven't they? So, you know, you've got to hit your first quarter, then you get the money, then the next quarter. Is there any talk about that being the same for this funding, accepting what you've just said, that the goalposts are moving all the time?
And I think there's a further complication to that, Andy, as well, in as much as the CCGs cease being in existence as of last week. So they have to do a final year, end of year audit process, and they've got to go through a full set of their accounts. Now, because the money flows through the CCGs, they therefore have to present a break-even position ideally, and therefore there is another complication in this about the way that they phase the ERF funding. So even if we chose to phase it in a slightly different way and chose to deliver more at the back end of the year, there is a complication in terms of the way that the funding flows. So effectively, as of this morning, we'll be phasing this in 12s, whether we think we've delivered it or not at this stage, and that's the view that we've been asked to take as an ICS and also in the region.
Which is probably pragmatic at this point, yeah. And then Joe, just a quick question, which I can guess the answer to, which is you've talked in the past about driving theatre productivity, accepting the challenges of resourcing and COVID and so on. Are you getting any traction around that, some of the things you wanted to drive in theatre productivity?
Thanks, Andy. Yes, so in June we had some more new theatre staff join us. There's obviously a bit of a time lag for those staff to get up to speed. And we've got a trajectory of new staff joining us in July and August. Tom Strickland, who's the Director of Ops for Surgery, has also carried out recently some engagement sessions with staff about how we can improve the process of getting patients to theatre quicker. And that's something that Brendan and I talked to Peter about recently as well. And get the start times improved and get more throughput on the list. So, and engaging the staff in that for their ideas. So it's still work in progress, Andy. But I'm seeing good signs.
Okay, you're encouraged.
Yes.
Yeah, good. All right, super. Thank you.
Okay, so thank you for that assurance, and I guess we'll note the ongoing risk of uncertainty really around the elective recovery fund. So thank you for that report. We'll take a very quick comfort break now, if we can just try and just keep it to 5 minutes. And we have at least done a little bit of, Gary, we're a little bit behind time. We've done a little bit of Gary's paper, even it's only a little bit of it. So 5 minutes and back, so we should be back. Thank you everybody for coming back promptly. We're now on to item 12, which is our finance report. We did start to drift into that a little bit in the last discussion, but if you could take us through the latest update, Gary, that would be good.
Okay, thank you. I'll be brief. So this is the position that as reported at the end of month 2. We're reporting a £6.07 million deficit, which is slightly ahead of plan. Good news. And as we just discussed as part of that last item, that is after not assuming any elective recovery fund income. So quite a good position to be in. The reason why we've not assumed any elective recovery fund is predominantly because we're still not quite there on day case and elective activity at this point in time. Overall, the CIP position is in a favourable position, about £800,000 ahead of plan at this stage, and really promising is that we've actually got the full £20 million worth of schemes and opportunities identified. Obviously, lots of work to make sure that we pull them all off, but actually the schemes are identified, which is a good position to be in. So at this stage, we continue to forecast to deliver the plan. We've got some challenges with the capital plan, so you'll see from the report, capital's underspending already at this stage of the year, and we're starting now to get some information about schemes that we've got planned for the back end of this year that may slip into next year already. So that's something that we need to give some time and attention to over the next few months. As I mentioned right at the start, this is the position that based on a 20 million deficit plan, which was our plan that was submitted back in April. But you're obviously aware from the press, there was additional funding that was allocated to the NHS, which involved us submitting a further plan in June. Based on that further funding, so more funding was made available to the NHS. This was really to support some of the inflationary pressures. That didn't mean that we've got more money to spend. It wasn't an opportunity to relieve any of the pressures. And the way that it's been received for us is that we've got to present it as a bottom line improvement to our position. So we've still got risks around inflation and all those other challenges. But what it does mean is that our deficit plan from £20.1 million is now a £17.35 million deficit plan. So as of next month, we'll be reporting against the 17 million plan, not 20. So I wasn't intending to say any more. That there's obviously lots of risks within the position still. We discussed them at Finance and Performance Committee earlier in the week, and we're still, the key risk for us in terms of delivering the plan for this year, we're still scoring as a 20, but happy to take questions.
So it's still early in the year, and like you say, we did discuss this thoroughly at the Finance and Performance Committee earlier. So are there any questions for anybody for Gary, or are we happy just to take this as a note of position at this point? Yep, I'm not seeing any hands up. So thank you very much, Gary, and we'll note the current financial position. Okay, so if we move on now to the people strategy refresh, and Amber's put us a link into it's like a video thing. It's quite interesting actually when you look at it, and it was sent out to people as well. If they didn't get the link, then it's on the it's in the chat today. And again, I think this has been through the Workforce Committee and been approved by the Workforce Committee. It did feel a bit sort of like passive just to note it here. I did feel that we should at least endorse it rather than just note it, and put our sort of weight behind our refresh people strategy. But I'll hand over to Suzanne just to give us a bit of just some of the headlines around the work that you've been doing, and Karen if she wishes to add to that.
Thanks very much, Helen. You've stolen my first line. So I would really love if the board could endorse the Refresh People strategy that launched on Monday, and also champion it, which a lot of you already do. So I'm going to bring it up, but I will do a whistle-stop tour, because Colleagues will already have seen it. So it's just to pull out the main points really, and it's nice, colourful to look at anyway. If somebody could just shout out, can you see that?
Yep.
Fantastic. So it's 3 years since we launched the Former People strategy, the cupboard, and the aims and the actions in that strategy definitely served us well throughout the pandemic, particularly in relation to our wellbeing support for colleagues. It's really timely though to refresh that strategy given the size and the pace of change we're seeing. But our overarching aim is the same, and that's to deliver one culture of care for our colleagues so that they can deliver one outstanding compassionate care for our patients. And we do that as just one partner in our health and social care system across Calderdale and Kirklees. So this is what do we want for our people? Just stealing another line from you earlier, Helen. This is about everything we're going to do to make this a great place to work, to keep people, to encourage people to join, to develop them so that we can deliver that outstanding compassionate care. The refresh strategy has been co-created with colleagues in their thousands actually across the trust over a period of 6 to 12 months. So we've used hot houses, worked together, get results sessions, tea trolleys, listening events, staff survey and pulse survey results. And we've also used some of the qualitative data we get through from Freedom to Speak Up, as well as our workforce health data. And we're delighted to be working with Kirklees. So we've just taken over the host role for the Kirklees workforce lead role. And we're also working with Calderdale College on building a curriculum for health and social care for members of the community within Calderdale and hopefully in Kirklees as well. And so there's some great work going on collaboratively across the health and social care systems that we serve. The feedback that we've had mainly focuses on clarity, ambition and scope of the aims that we had in our previous strategy, the cupboard, and it's how we're going to make ourselves an employer of choice and support our workforce. So the aims and priority areas of focus have therefore been set into some clearer chapters, which we'll come on to later. Colleagues wanted some real clarity around one culture of care and the importance of our values and behaviours. And they also wanted to see how our 4 pillars and one culture of care fit together. So there's been a huge engagement as well on our values and behaviours. And you might spot that we have changed the people, we put patients first pillar to put people first. Our colleagues were really clear about that because they want us to see patients as people, as family members, as mothers, as fathers, as sisters and brothers, but also it gives the emphasis to the fact that 80% of colleagues who work at CHFT also live in Calderdale or Kirklees, so we are also the patient too. The strategy provides a golden thread from the NHS People Plan and also then to our West Yorkshire Health and Care Partnership and our own 10-year plan, which we've already covered today. And it firmly places CHFT as a key partner of the health and social care system. So again, a link back to that importance of the ICB and the role it will play. As previously mentioned, there are 6 key chapters. So these are the 6 key areas of focus that we think will help us understand and progress what we need to do for our people to give them a great experience here at CHFT. And each one of those chapters has a clear statement of intent. So, for example, the first one, which is equality, diversity and inclusion, is we celebrate difference and we are inclusive. And there's a lot of work that's gone on here recently. Each chapter might also have sub-strategies, so I won't click through to these because of time, but there are some supporting documents and supporting action plans and sub-strategies for each of these chapters. But in line with the feedback that we've had from colleagues, we've stripped a lot of the content back. So it's really salient, it's really clear, and colleagues can absolutely understand what we're trying to achieve. Our other chapters, health and wellbeing, so we prioritise colleague health and wellbeing. We seek out the views of our colleagues and act upon them. Improvement, we will continuously improve services to patients, and there you'll see some of the work together, get results work that is undergoing a refresh at the moment, and also TED, which is our team engagement and development tool to help colleagues improve their staff survey scores and the environment and experience of colleagues within those services. We also have talent management, a lot of work gone on here that has been picked up since pre-pandemic, dusted off and further improved. So in there you will have a talent management framework and a recruitment strategy, and also a development plan for all, which is kind of like a brochure for all the training that's on offer for colleagues. We then have workforce design, really important for reconfiguration. So these are the tools that we're going to be using to use to develop our workforce models and our skill mixes as part of the transformation programme. And those commitments are all set out really clearly at the end of the strategy. We also have in there how we're going to monitor our progress against those action plans that appear in the strategy, so that we can really demonstrate on the return of investment and whether we're going in the right direction. So I'm just going to take that down now so that I can see everybody, just in case anybody has any questions. But there's a lot of work gone on. We're having a hot house this afternoon, which is to take colleagues through that to make sure all our leaders and managers are aware of our key priorities. And as this is a collaborative and co-created piece of work, we want to really say thank you to the colleagues that have played a part in it, and we will be communicating it thoroughly over the next few weeks. Thanks very much. If you have any questions.
Suzanne, so Karen, are you wanting to add to this?
I just do want to add a couple of points. I think this is a great piece of work. I think it's a living document. It's not something that stands on its own. It links into the main strategy. It's clear and succinct, which is what we needed, and it builds on what we've learned and what's been actioned throughout the pandemic. I think the point I want to make is this is everybody's responsibility to take this forward. It's not just Suzanne's and her team. It's every leader, every manager in this organisation, and ourselves as a board. And clearly, as a workforce committee, we will be monitoring progress as we go along. And your endorsement would be absolutely great today. But really, I just want to emphasise it's everyone's responsibility to make this happen, because we have got, as others have in the NHS, serious workforce challenges ahead of us.
Suzanne and I spent a little bit of time earlier this week sort of talking about how do we know we're delivering this strategy. And yeah, there's the hard measures and metrics that we always have for people, you know, that we wheel out time and time again, but actually what's some of the real meaningful softer measures, and how do we get some sight of that at a board? Not in the massive detail that you have at your committee, and Suzanne shared. I think it's still downloading on my computer. She shared that much stuff, but I think there was, you know, the real sort of the depth of how do we really know we're delivering against this people strategy, and how can we bring some of that to life? So I think it's, you know, I think you absolutely make a good point. It is everybody's business. This is I would suggest, our number one big risk in the whole of the NHS is keeping our workforce motivated, keeping them, you know, enjoying their work, keeping them in their work, and then, you know, recruiting from, you know, to our vacancies. And I think I made the point to somebody the other day, I can't remember who it was. It was a bit of a, it says we've got, you know, we serve a population of around 600,000 people. We only want 1% of them to come and work for us. It's not much, is it? It's not much to ask. 1% of them.
No, but I think I'd just like to add that data tells you one thing. That's great, but it doesn't give you the real lived experience, and it's how you capture that. Not just the data. Data's one thing, and data's important, but it doesn't actually always reflect the real lived experience that people.
That's right. That's what Suzanne and I were picking up. This, you know, how do you get to that depth, that reality? So thank you. I haven't got any hands up, but there's a thank you in the chat from Andy, and people like the way it's presented. It's quite easy to follow through, and like you say, you can click through and see more information. So thank you both very much for the work you've done on that as well through the Workforce Committee, and we will endorse that as a board, and then ensure that that we bring it to life as well through some of our discussions. Richard.
Thanks, Helen. Sorry it was a bit late. It was just to say, one, I think it's an excellent sort of piece of work and a great document. I think it's very timely in terms of refreshing it, and certainly I think those sort of 6 key chapters, and I'm particularly interested in the health and well-being side in my current role, which I'll be shortly passing over, I think, to Denise, but as health and well-being guardian or well-being guardian. So I think it's great. I mean, and I do take the point about the softer measures, and that is obviously important, but you probably expect me to say that one of the outcomes of this will also be in terms of some of the hard data, and we know we've got challenges around absence still. You know, that number, it might be improving slightly, and it's probably better than most of the other trusts in the region, but you know, and the last numbers I've seen, it's at 4.9% excluding COVID. It was at 3.5% 2 years ago before COVID. We need to find a way of getting that back under control and down. I know there's a lot of hard work doing that, and I think, as Helen has mentioned, you know, vacancies, we need to make sure we're doing a lot of good work there, but the proof will be whether we can fill those vacancies, whether we can retain the staff, and whether we can get that absence rate down. So, you know, I would certainly endorse the strategy. I think it's a great piece of work, as I say. I think it's very timely. The proof will ultimately be in terms of both those harder and softer measures going forward.
So with that sort of endorsement, we will move on now to the first of a number of annual reports that we've got today. So the first of this is our Dixie annual report, which I believe Lindsay is going to talk to. Now, I understand you'll have had quarterly reports of this, and so no doubt you'll have followed the journey of this report. So bear with me because I haven't. But Lindsay, can I just invite you to just give us a quick summary of our annual report in terms of infection prevention and control. Thank you.
Yes, thank you, Chair. So it's remained obviously a very active year for the infection prevention and control teams. This annual report summarises some of those key activities that we have to undertake around providing assurance to the Board of Directors that we've met our statutory requirements as an organisation and within those policies and procedures within infection control. A number of points to note around in terms of our performance. So starting with MRSA, we've had a 0 case reported in this year, so a real positive for us in terms of meeting that objective. We have seen, however, an increase in C. diff throughout the year, and we breached that target back in November of 2021. And although we've had an increase in cases, what we have had is a significant decrease in those cases which were preventable. Going through the root cause of those cases that were not preventable, we had a range of issues in relation to antibiotic prescribing. So page 12 of the report contains a number of actions that we're undertaking around antibiotics to address any issues that were raised through 2021-22. So those describe those, including the sequin indicator that we'll be working towards around UTI. Also to note is the ongoing performance around our COVID cases, including the outbreaks and the ongoing variants that we're seeing, which are causing peaks throughout the year, and we've had to respond to those. And I think you've got some data in the report that clearly shows the position at CHFT as we went through those various waves, particularly around the Omicron variant and the second variant of Omicron, which you can see through there. So, and finally, on the page 18, you'll see a forward-looking plan for infection prevention and control around obviously responding to the ongoing emergence from the COVID-19 pandemic and continuing to respond to new guidance as that's issued, to work across a regional footprint around CDIF because other organisations have also seen an increase. So there's some work across the system around antimicrobial prescribing that we are going to participate in, and various other training strategies and the implementation of the new cleaning standards across the organisation. So currently, just an update for the board in terms of where we are. We're currently seeing an increase again in COVID in the local population, and I think that's well published nationally at the moment. So in terms of what does that mean for us here at CHFT, we've had to increase our bed base at the moment in terms of providing isolation areas for COVID positive people within our services. We've seen for the first time in a number of weeks admissions into critical care, so we're keeping a close eye on that as we go through this peak, and the peak is expected to run throughout July and probably for the main part of August, and we're starting to see some impact now on staff absence related to COVID as well. So we've had some guidance published around a winter vaccination programme, which will be due to start in September regarding COVID and flu. So we're just working through that guidance and our response to that. And we're also received some updated guidance around monkeypox vaccination programme, and we'll be offering an occupational vaccine to colleagues who work in those services that have been deemed as high risk by the centre, and that's in the main the laboratory services and sexual health. So the look back, you've got it contained in the report, the look forward about what we're doing, and then I've just given you a brief update on the current position, particularly in relation to COVID, the vaccination programme and monkeypox. So I'm happy to take any questions.
Okay, thank you very much, Lindsay. Thank you for covering that comprehensively. And in case I forget after questions, if you could just pass on the board's thanks to the IPC team, I think, for the work that they've done throughout the year and what has continued to be very challenging for everybody, I think. So, Andy.
Yeah, no, thanks, Lindsay. And good to see positive progress in things like preventable C. diff and MRSA. So I know whenever David presents these reports, it's often an up and down journey, isn't it? And can you actually really drive some improvements? So good to see that. COVID outbreak, clearly a concern, but you talked us through what's happening there and so on. So nothing I think I'd like to ask on that. Just two things in the report. So there's a board assurance, a BAF in there, talking about a number of actions. And again, generally very good progress. But one area, cleaning, like 7 actions still in progress. Can you just give me a flavour of, are there any key concerns in there? And then later in the report, it talks about for 22-23 plan says reset and stabilise the IPC functions. Can you tell us, what does that mean?
Yeah, so in terms of some of those cleaning areas, that's around the ongoing stepping up and stepping back down around some of the different cleaning standards, responding to the ability to do the deep cleans and those programmes, and then the introduction of the new cleaning standards. And there were some challenging targets that came through some guidance around cleaning in those high risk areas and the frequency of those. So that's an ongoing monitoring of those areas to make sure that we've got that embedded in terms of that. In terms of resetting and stabilising the IPC team, so obviously they've been working in a very reactive programme. We've had to step some of the audit programme down throughout last year to be able to do the urgent and emergency work that's been required. So it's just about going back to that stabilisation of the ongoing infection prevention control programme, stepping back into some of those audits and some of that preventative planning work rather than some of the reactive work.
Okay, so it's not about a team issue, it's more about refocusing our work back to more BAU if we can.
Yes.
Okay, all right, thank you.
Presumably that reflects just the way their working patterns and arrangements have been completely disrupted, haven't they, by COVID? Okay, thank you. So
yeah.
I guess so this is a requirement that we have to take an annual report and be assured that we had effective systems and processes in place for infection prevention and control through the year, which nobody's challenging that here. Obviously with 1 or 2 questions of clarification. So thank you for that assurance. And then we're also here to note the objectives for the coming year, and no doubt we'll then get quarterly updates against those objectives. Welcome. Is everybody happy and content to do that? Yeah, I'm not seeing any objections, so thank you very much for that. So thanks, Lindsay. So I think we now move on to Cornell, who is going to, and again, another annual report in terms of the learning from deaths. I'm again assuming that you've had these reports before, and this is the sort of the final one that comes through in terms of our assurance. But there are some very specific recommendations on this report as well. So Cornell.
Good morning, everyone, and welcome, Helen. So yes, it is true that there are quarterly learning from deaths reports that come to board, but this is also the annual mortality report. So it's a particularly hefty report, which I'm presenting as the Trust Mortality Lead. I will keep it brief. There are 3 elements to mortality surveillance and assurance, and they comprise the metrics, including the NHS digital alerting system. The second element is case note review, and the third element is themes and learning. Firstly, the metrics. I'm reporting us as being in a stable position. Board will be familiar with these metrics over the years, but our standardised hospital mortality index is stable and it's in the expected range nationally. Our benchmark crude mortality is stable, and our hospital standardised mortality ratio, having sustained an adverse shift in the latter 6 months of 2021 owing to issues it transpired with specialist palliative care activity and coding, has now started to correct over the last 2 releases and again is in the as expected range. We've refined our processes around mortality alert reviews, and this multi-staged approach is detailed in the paper. And it's also the case, again, for some assurance, that recently the volume of our national mortality alerts has declined. Secondly, case note review. So the board will be aware that the metrics are not a direct measure of quality of care. And we have a 2-tiered mortality scrutiny, initially through initial screening reviews, whereby doctors within each specialty review case notes. Our internal target is 50%, which we have struggled with historically, and I reported an achievement of 47% in the paper, but it has actually now risen, I'm pleased to say, to 50.5%. So that means that half of our deaths undergo case note review, which provides a strong level of assurance. Our second stage process is structured judgment review, for which we've got a full complement of 8 senior doctors who provide detailed scrutiny, and the figures relating to that are detailed in the paper, but approximately 10% of our deaths undergo structured judgment review. It's also worth bearing in mind that with the establishment of the medical examiner office, which, although not a formal part of our learning from death process, these are also senior doctors who are reviewing case notes of all deceased patients within a matter of days, usually following death, and they can and do escalate through the structured judgment review process and through our incident reporting process. The medical examiner office is led by our lead ME, Dr. Tim Jackson, and they're now scrutinising 90% of inpatient deaths and making contact with approximately 80% of bereaved relatives, which allows us to identify much earlier concerns that relatives may be raising. So I think we have a very strong, robust case note scrutiny process. The third and final element relates to themes and promoting learning. The themes are articulated in the paper around Mental Capacity Act compliance, learning disability, patients, deteriorating patients and end-of-life care. And all of these areas form part of work streams and extensive improvement work, which is underway, including the care of the acutely ill programme, which is now fully established. Learning occurs within and across divisions and through incident investigation with various assessments to see if it's embedded, for example, through the J2O visits. And finally, the recommendations which are provided in the cover sheet. I'm looking for the board to note the first and to endorse the other two. So the first is to note, and that's there is a plan for expansion of the medical examiner service. It will become fully statutory in April of this year. It is, we host the ME service rather than it being accountable to us, and central funding is available for this expansion, and it will be expanded out into the community, and we're looking to recruit additional members of the team, including colleagues from general practice. The other two recommendations, the first is around learning disabilities. We've talked already this morning about health inequalities, and there have been some care concerns emerging over the last 12 months in this very vulnerable group of patients. We do need to prioritise this area, and there is a detailed action plan outlined in the paper, with it now being brought as a work stream into the care of the acutely ill programme to agree and complete outcome measures. In respect of the third recommendation, this is centres around the deteriorating patient, and I think should include sepsis. And I feel quite strongly that we should consider a bespoke quality improvement programme rather than just a work stream to focus on a range of things in this group of patients, specifically monitoring, response and escalation. Thank you. I'm happy to take any questions.
Okay, thank you very much. A very comprehensive report. Can I invite any questions for Cornell? She's a bit fastest finger first, this isn't Andy. Do you like set yourself a bit of a challenge? I'm going to get straight in. Andy?
No, not particularly. So Cornell, thank you for that, and thanks for kind of your voiceover, Robert. That was very clear. Good to see some improvements in kind of ISR and kind of structured judgment review stuff, doing more of that. I think that's good to see. And it feels like the medical examiner officers, had a real impact. Just two things from me. Just to be clear, and we've talked about the HSMR, never get the acronym right. Is this a coding issue in the palliative care team rather than a care issue? Just to be clear about that. So it's a data issue, we've got to get the data right. And then my second thing was just, it's interesting to read the medical examiners talk to relatives. Are there any key themes that have come out from medical examining officers talking to relatives?
Thanks, Andy. So in answer to your first question, it isn't a coding issue per se. Whenever there's kind of mortality metric drift, we tend to assume it's some form of coding in the first instance, so we scrutinise that very carefully. The issue really relates to the fact that there is a particular code that only the specialist palliative care team are able to use. And over the last 18 months or so, that team has firstly struggled in respect of staffing, which has been one issue for them, but actually also in terms of increasing complexity of the patients that they've become involved with. So the volume of patients that they've seen has declined. And because HSMR is adjusted, as you know, for this measure, that has caused us significant problems. It doesn't take much of a shift in those numbers, and there's a chart which I can't remember if I included in the paper that demonstrates this. It doesn't take much of a shift to have a fairly dramatic impact on HSMR. We are addressing that through how that team works, and as a result of that, the last two data points are trending in a better direction.
Okay. All right, thank you.
And sorry, what was the second question?
The medical examiner was about, you know,
Oh, yes,
talk to
bereaved
relatives.
relatives.
Yeah, so
Yeah.
are there any key themes that come out of that?
No, not particularly. But what it absolutely allows us to do is have contact with relatives a lot earlier to either directly address their concerns or to expedite them through the complaints and sometimes the incident process. And that input has been evaluated and is received very positively by our bereaved relatives, but no particular trends in terms of care.
Okay, all right, thank you.
Thank you for that. Karen?
Yeah, I just wanted to add, I thought this was an excellent report, very detailed, very clear, and just to say I support the recommendations and wish you very well, Cornell, on your next stage and chapter in your life.
Thank you, Karen.
Thank you. And Richard?
Thanks, Helen. Yes, Cornell, a bit similar theme from me. We have had various discussions around some of these statistics historically, and with both you and David, particularly around initial screening reviews, etc. And it's great to see that we seem to be at last making some good progress. And from your personal point of view, it's good to be going out on a relatively high in that respect. We've still a bit to do to get over that 50% target, but we're getting pretty close. So yeah, as you say, I think it's generally a very positive report in terms of where we are. So congratulations on that, and best wishes in terms of your future role. I would just add one more thing that I found it interesting that there's reference in this report to Poisson distributions, and I knew that my A-level statistics would at some point come in use. So I almost understood it.
Thank you, Richard. Put that in especially for you.
Thank you.
And Denise?
Cornell, thank you very much for presenting the report this morning, and you know, I concur with everything that's been said by colleagues so far. I just want to add my kind of support in terms of recommendations that you've presented to the board this morning, and particularly around the recommendation for a quality improvement programme for the deteriorating patient. I support. I think that's something that we need to do, and actually I'm looking forward to hearing how we're going to get that programme up and going.
Thanks, Denise.
Okay, thank you very much. So I think we've got support for the recommendations in the paper from what people have said, and again, from things that have obviously been raised previously, they've now been addressed through the report, which is good from an assurance point of view. So we're happy to move on from this item. Thank you very much for presenting that. I know we can't quite let you go just yet because you're doing the next one as well. So we'll let you move on to the quality report, which I think you're doing.
I am.
Yeah.
I am. Yeah.
Wow.
No, thank you, Chair. So in terms of the quality report, this will be even briefer, I suspect. There'll be a slightly different approach going forward with this. So presentation of it will alternate with each board between the chief nurse and the medical director, although both will take questions. And you'll also see another change is that there is a standalone summary slide deck, which is effectively an executive summary. I draw your attention to these slides and hope that the board finds them helpful, but want to just pull out briefly a couple of areas to highlight. The first is complaints. This has long been a challenge and is one of our focused quality priorities. Additional measures have now been put in place, and already as a result of this, there has been some improvement with an increase in complaints closed within the target time frame, which is a fairly key metric for us, from 35% in April to 57% in May. So the things that have been done include a dashboard for complaints on our knowledge portal plus business intelligence portal, which helps support the divisional teams, monitors performance, and an escalation process is now in place when timeframes are breached. There is a weekly confirm and challenge with involvement of the Chief Nurse and Director of Corporate Affairs, and the new Parliamentary and Health Service Ombudsman complaint standards have been reviewed with the Trust considering being an early adopter. The other thing I just wanted to mention was sepsis. So the recognition and timely treatment of sepsis is a quality account priority. Details of this are in the slide pack and in the report, but there is reasonably good progress this year against measures in the sepsis 6. Again, this is one of the work streams within the Care of the Acutely Ill programme, although there's still work to be done, especially in relation to blood cultures. We are, however, getting an interface between our electronic patient record and many of our point of care tests, which should be in operation later this month. And this is important because a number of things will be pulled automatically into the record, and that allows us to audit and monitor compliance with them and improve compliance with them for measures such as lactate. Sepsis skills training is now also in place and is part of our essential skills training. However, as per my presentation just now on mortality, I would propose that sepsis is pulled in with the deteriorating patient programme because we have still got progress to make, for example, against the administration of intravenous antibiotics within an hour of identification of red flag sepsis, which is currently sitting at 65%. So there is scope for improvement there. That's all I'm going to say. I'm happy to take any questions.
Okay, thank you. I don't know if Denise, do you want to add anything as chair of the Quality Committee? You're on mute.
Just to say that the points that Cornell has raised, we've covered in quality. Actually, we spent quite a bit of time just considering the quality priorities as well. So in terms of that oversight, we're on that.
Thank you. And I'm glad you confirmed about, so Lindsay and I met as part of my induction this week and we did talk about sepsis because there's been quite a lot of stuff around NHS providers about board sightedness on sepsis and what the trust board's doing about it and da-da-da. And so I guess, you know, for me, I'm thinking, I was like, oh gosh, you know, how do we get into this sort of thing and level of detail? And obviously we've got our quality committee, but it sounds like there's a whole sort of set of stuff going on around sepsis. Maybe at some point we need to draw that out specifically in the quality report, just so that we've had the opportunity to consider that at a board level. But it is a rather casual thing that I think they often do nationally, which say, oh, trust boards need to ... and we need to think about how we do that, but again, be respectful of why those things get escalated up to that level. Andy.
Thanks, Cornell and Lindsay as well. So I think some encouraging progress in here. I was looking at pressure ulcers as an example. Some of these things, it's hard to kind of turn the corner, isn't it? And indeed, it feels like we've turned the corner on the falls work. We've had the falls collaborative team there for some time, haven't we? So hopefully, I'm sure you would agree with this, that if that collaborative is working, we're starting to see the impact of that. So let's hope that's sustained. Complaints is definitely one, Cornell. I mean, I'd looked at this before. We've looked at it a number of times. I'm still sceptical we've got to the bottom of this, I have to say, because we've had the numbers move around. And what is the real cause of us not cracking this? Is it about skills of people doing it or whatever? So I think there's more to do there. And something that somebody said to me before about is not only about the process, but how good a job do we do about learning from complaints? So I think we've been focusing a lot of effort trying to improve the process. I wonder if we've still got more to do about learning from them. So I'd just be interested in your thoughts on that. And then the second question would be the medicines management, clearly a concern. You know, what actions are we taking to get this back to, we view it as a must do, wouldn't we, about doing this? What other actions are we taking? It's one thing to look at a review of locks on doors, but that's not just the issue, I think. So what else are we doing about medicines management?
So I'll let Lindsay come in on the complaints part, Andy, if that's okay. And if that's okay with you, Lindsay.
Yeah, no, that's fine. So Andy, in terms of that, the numbers going up and down. I think we've seen that, haven't we, through the performance data. But we have put an additional process in place now. So there's the training element that is around making sure people receive the right training element around complaints and the timeframes, and that the divisions have got the right infrastructure in place to support the work that's been doing. And then we've got the confirm and challenge, really, is around maintaining focus, not on those complaints that are already out of time, but those that we're not sure that we'll respond to in time, so that we can put remedial actions in place, and that takes place every week with the clinical divisions. And then we're supporting one of the clinical divisions around working with them through the corporate team to provide some additional support in terms of getting those processes really robust and in place. I think you'll see through the patient experience strategy that part of one of the elements is around the learning from complaints, learning from incidents, and that'll be a key focus for us as we go through this year in increasing our confidence that we are learning from complaints, and that those lessons that we're learning are embedded in practice. So that there's two things in that: there's what we have learned and what we can be assured that people are aware of, and it's made a change in practice, and we could articulate what those changes have been as a result of that learning.
Okay, so that's a go forward thing. The training, I think, is something I remember when I looked at this before, was often raised by divisions. It would be not got enough resource or got enough people with the right skills to handle the complaint. So hopefully, yeah, the training will address that. Okay, thank you.
Okay, thanks. And the meds management point?
Shall I take that, Lindsay? Or yep, okay. So yeah, completely agree. There are still issues here. The staffing pressures that we've experienced over the last 12 months haven't helped this. I think colleagues have taken their eye off the ball slightly. It's certainly an area that our colleagues in the CQC take an active interest in. One of the things we have been doing, which I can describe to you, Andy, is in terms of the J2O assessments. Not only does this pick up on issues specifically, and there's a very detailed section around assurance in relation to medicines management as part of those assessments, which are going on in all clinical areas, but then there's also there are improvement and action plans which are bespoke for those areas in terms of resolving some of the issues that we're identifying. But yes, I agree. I'm with you. I think it is an area of concern and requires continued focus.
Okay, all right, thank you.
Right, and I presume that gets picked up through the work of the quality committee in terms of doing that sort of more in-depth look at. Yeah, thank you very much. I'm very conscious when doing these that you'll have all discussed lots of this lots of times, and so you know, just being sort of respectful of that and mindful of that as well. So if there's no, oh, Brendan, sorry, I not spotted you there, top of my list.
Oh, thank you, Helen. Look, I'll be brief. I might draw Vicky in if Vicky wanted to comment, but there's a root and branch review needed in all of this. I think there's our statutory reporting that we need to consider as a board, but I think to Andy's point about complaints, this is much broader. How do we learn from what's happening, and how do we consider whether this is influencing future practice? And I think we should revisit our nomenclature around journey to outstanding when we see the performance that we've just called out. I think, you know, there's a contradiction in terms there, and we need to consider that going forward. I think it speaks to the subcommittees and it speaks to reporting to board. I think, Vicky, did you want to comment on this? But I do think we need to think differently about reporting, commentary, learning, and how we want to improve. Vicky?
Yeah, so there's something for me about some of the detailed conversation that we've been having, how that happens in the subcommittees. And so that what this board is really looking at is exactly what Andy called out in terms of the learning, the levels of assurance that we get. So I won't drag it out now, but I think there is something we need to do about that for this and the previous report, I think.
The ones to come as well, particularly in terms of the IPR, etc. I think that's another one that lends itself to trying to get the balance right. So Vicky and I just offline have had a bit of a conversation this week about perhaps some board development work around subcommittees, assurance, governance, and how that sort of flows in terms of getting the right things in the right places and the right people involved in the right conversations. If we're relying on people who sit in subcommittees to provide that level of assurance, then have we got enough of us, I guess, put in those particular places? So I think that is a bit of work in progress. I think we carry on as we are at the moment, but I do think there's a bit of there is a bit of work to do there that Brendan's referenced. Okay, but if we're content to note the contents of the report, those of you who are very familiar with all of this will see what's improving and the journey you've been on, and I will rely on your sort of take on that in terms of the assurance. But that is now your last item, I think, Cornell. So thank you so much for coming on your last day, perhaps even, I think, in the trust, and wish you all the very best for the future. And thank you for giving us a bit of you on this last day. And I'm sorry I won't get the opportunity to work with you, having just started myself. All right, thank you.
Thank you, Helen.
Okay, so if we move on now to our response to Ockenden, which is back to Lindsay, then again, it's another one of those when I know you've had regular updates. So if you want to just maybe focus on what's changed and what we need to know as a board today.
Thank you, Chair. So this is the update to the board in terms of that final publication of the second Ockenden report, which was published in March 2022, which built really on the first report, and they made a further 15 recommendations around the immediate and essential actions that organisations needed to respond to and demonstrate compliance going forward with those. So the Maternity Services has reviewed that report, and we submitted an action plan to previous board regarding the maternity transformation plan. We have since had our regional and system assurance visit around the first 7 essential actions, and I'm pleased to be able to report to the board that was a positive visit in terms of our position and compliance against those areas of focus that were in the first report. Some of the headlines that we got fed back to the service were that staff in all areas were welcoming, willing to speak to the visiting team. It was clear that we had good governance processes with a real focus on patient safety being a priority, and that was valued by the teams. They commented on our open and responsive culture. There were some good practice areas, one of them being the weekly view newsletter, which shares lessons learnt and learning and provides feedback to colleagues within the service, and that was really valued by colleagues when they did the visit and they did their interviews and they did the walk rounds. They could see evidence of staff involvement in developing new processes and risk assessments. They felt that we had a really good relationship with the chair of the Maternity Voices Partnership, and they felt valued in their role and they felt listened to by the service. They felt we had comprehensive training packages and that we learnt from incidents and complaints, and we have the relevant national policies in place and we could articulate those locally. They could see the real value of our end-to-end maternity system, but they could really see that we'd got personalisation of care embedded and that we'd got measures in place to monitor and audit that. They could see clear evidence of the team's commitment to addressing inequality, and they could see that audit was well embedded in everyday occurrence and that people felt responsible for that and areas of good MDT working. So I think that's a real positive in terms of, you know, what we saw in the Ockenden report and what the review of our services has been fed back in relation to that. So a real positive for the team in that regard. This report also highlights our position around continuity of carer, in that we continue to provide antenatal and postnatal care within that service, but we've paused around our intrapartum part, and that's to really focus on, particularly around our health inequalities and the women that are accessing that service. We've also appointed 2 independent clinicians from the service to do some further assurance around compliance against the action plan, and test out and talk to colleagues around where they feel we are against that plan, just to add that added level. And Suzanne, from an OG perspective, is also working with maternity services around that real organisational development wraparound within there. So I think this report provides the required assurance to the board that we are responding to the Ockenden reports, that we've got a comprehensive action plan in place, that the assurance visit has been positive from the regional team, and the recommendations from the regional team were just around strengthening some of the things that I guess COVID has brought about in our ability to have face-to-face meetings with the Maternity Voices Partnership. And I'm happy to take any questions.
Okay, thank you very much, Lindsay. It struck me when I was listening to you, the point that Karen made right at the beginning of the meeting around the sort of working out, you know, in partnerships, and this is a really good example, isn't it, where there's almost a naturalness to maternity services working in those sort of partnerships and the value it adds. Okay, questions. So I got Peter.
Helen, thank you for that. Lindsay, thank you for that. I thought I just wanted to say I thought the report was really clear. Not that I was expecting it not to be clear, but I just thought it was really well written and really clear, and I could really understand the issues. So thank you for that. The only question I had was around the maternity improvement plan and reference to the independent clinicians. Just for my understanding, are they people from outside of the trust coming in? Are they who are they, and where have they come from in terms of the review?
So one of them is internal and the other is external. So Cornell and I have been, and Suzanne, etc., have been working with that team. So one of them is our anaesthetist, PNT Lalo, who's obviously got real skills around human factors and a real strong safety focus. And then the second one is an independent midwife from the within the LMS.
Okay, that's great. Thank you for that.
Karen?
Yeah, and I'd just like to add that the transformation plan is extremely detailed and very thorough. And I think sometimes, Lindsay, we're just a little bit too harsh on ourselves.
We are.
Criticise. I mean, sometimes that's not a bad thing because it's not about complacency. But sometimes I think we do really beat ourselves up a bit too much. I think one of the things that came through very strongly for me on that assurance visit was how the staff came back from having done their bit so enthusiastic, and the feedback that they were giving you was really positive. I mean, it was genuine because their eyes were lit up and their whole expression was really positive. That was really good to see, where people were working together to be open, honest and transparent, but actually also really pleased about the feedback that they were receiving and the positivity from that visit as well.
Yeah, it was really palpable, wasn't it, Karen, in the room, that there was cohesion, that the team were happy.
Yeah, they were. Yeah.
And the team, the external team, really fed that back, didn't they? So you're right, Karen, that the plan and the transformation plan, it combines both Ockenden and various other assurance plans within maternity services. And where we've got some red scores, I think we're being hard on ourselves there. So we're going to review, obviously it's an ongoing review around that, and publish that together in terms of more of a board assurance framework plan that the transformation plan would look like going forward, so that we can really focus on the areas that we need to focus on as exceptions, and celebrate the areas where we're doing really well.
Yeah.
Okay. Thank you. So that's so in terms of I guess the basic level of assurance, we're sort of there. We know what actions we're taking around continuous improvement. There's perhaps something in that refresh in terms of us then I guess it's speaking to that point about not, you know, maybe being more I want to say realistic, that might not be the right word, but you know, maybe being less harsh on ourselves, I suppose, and thinking about this maybe more objectively, that we could pick up in our future reporting. Okay. If there's nothing else from anybody else, thank you very much for that report. And I think, like Peter says, it was very clear, particularly from somebody like me who's not of, you know, new to some of these reports, being able to understand straight away where we are with things. That was very helpful. Okay, so now we move on to so the integrated performance report. Now, just before I hand to Joe, this has been through the Finance and Performance Committee, and I've also had a conversation with Joe and a conversation with a couple of other colleagues, including a couple of the new non-execs, around the integrated bit of it. Because if it was integrated performance report, we wouldn't have spent 10 minutes on a finance report and 10 minutes on a quality report, because we'd have been doing it all in an integrated performance report. So I think there's a bit of a question sitting around the notion of an integrated performance report. So if we perhaps at this point it is about a performance report around some of those sort of key points, and a lot of what is in here somehow, somewhere, has been reflected elsewhere in our discussions today. Of course, the challenge and the is always the information in here the same as we've had in those other reports, and that's always something that people often spot, sometimes due to timing and things. But Joe, I'll hand to you to draw out of here what we've missed in our previous discussions, rather than needing to repeat them.
All right, thank you, Chair. Yeah, as you say, we've already talked about some of this stuff in here today. So just some key points to note. I think the sustained pressure in urgent care is something we should note. 12% rise already year to date, and that pressure has not gone away. The COVID numbers remain stable. I know Lindsay's referenced them. We have seen a slight increase in COVID admissions over the last couple of weeks. I think to note the cancer performance against the key cancer standards, we haven't talked about that today. We achieved all the standards with the exception of the 62-day screening standard in May, and that was obviously great news for our patients, and continues to be a challenge. I'm not going to pretend that's easy against all the other things that we're trying to achieve. I would also just note the transfer of care position, which remains at 80 or below. Now, I'm not saying that number is brilliant. It should be lower than that, but we have seen a sustained decrease in that number, and that reflects the work that my teams are doing with our system partners and the relationships we're building with our system partners on how we get the best care for our patients. So it means patients are accessing care in the community quicker. However, there's still work to do on this, and a lot of work ongoing around how we actually admission avoid with some of these patients and stop them getting into crisis. Those are the key things really I would just draw out. Obviously, I'm always happy to take any questions.
Yep. Okay, thank you very much. So in terms of questions on those or any other areas that people were concerned around, Andy?
just on ED, Joe, just a quick question. So the 12%, is that against pre-pandemic levels, or is it kind of against last year? And the second question is, when we've talked briefly about ED before board, you'd have talked about observing differing performance between different ED teams, you know, and so that was one of the issues you were looking at. Was that a cause of some of the performance in ED? And I wonder if you could just comment on that.
Sorry, repeat that second question, Andy.
So the second question was, you'd have commented before when I'd have asked about ED that one of your observations have been differing levels of performance in ED teams. Yeah, so in terms of kind of wait times and moving people on and so on.
Yes.
And you just commented on that, but when we last discussed it, it was just an observation of yours and you were going to pursue it. I'm just interested, is that still an issue for you, and where are we getting to?
In terms of the clinical teams in A&E,
Yeah,
do you mean?
Yeah.
And response times.
Yeah.
Yeah, I mean, that work is ongoing. I think what we should note is that you know, there is a difference, and we talked about this at the Finance and Performance Committee. There is a difference in the demand that's coming in at night time versus what's coming in during the day.
Okay.
And we do have differing structures in the teams, particularly at night time. There are more gaps at night time in terms of the medical staff. It's still safe. We're providing a safe service, but there are more gaps at night time in terms of that doctor cover. So, and the response times will be different at night time. So what we're doing is trying to level out that staffing across the heat map of the day, and each day is different. Monday, Tuesday, Wednesday tends to be different to the rest of the week. And we're trying to align the staffing levels to that. We're trying to use the you know, things like time to triage, time to referral, time to response to referral, and look at each individual teams. So, you know, what's the response time from surgery? What's the response time from orthopedics? And then we're trying to instigate some professional standards around that. And the professional standards exist already, but it's actually making sure that everyone uses them. And I think there is a bit of fatigue with some of that. And we've got a reset week planned in August, where we will refresh and remind people about those internal professional standards. And we will try some new things as well against those, you know, to try and improve against those standards. Because we know that at night time people do wait longer than perhaps they do during the day. So trying to even that out. So I think there is work ongoing around that. I think we need to note the gaps in medical staff, and although we are successful in recruiting consultants for our emergency teams, it's not quite the same at other levels. Although there has been, I mean, I'm sure Cornell can update, there has been recent success in the number of doctors we've managed to recruit into urgent care. Does that answer your question?
No, it does. No, it's good just to hear, because it's a step on, isn't it? What things you're looking at to try and improve things. So that all sounds, that's very helpful. Thank you.
In terms of the activity, the comparison, I think it's against pre-pandemic levels. I think what Peter's done is a comparison of pre-pandemic in terms of not those first few months when no one came to urgent care. So you know, it is a 12% rise against the last few years. I can obviously bring back to F&P a bit more detail around that activity, and we can look into that in greater detail. That might be something to look at, and we can, when we look at urgent care in more detail, we can track that activity over the last couple of years as well.
Yeah, I mean, Gary has put a data point in the chat for me around 1920 levels and a comparison to there, so that's helpful to see, because the obvious question is, we achieved higher performance in A&E in previous years, and it's just trying to, is that volume or is it some other things? Obviously, it's the question I'm kind of trying to angle at.
Yeah, I agree with you.
It's difficult to do.
It is difficult, but what I would note now is that, you know, the patterns of demand have probably changed compared to where we were. We are seeing, and this is always a bit of a, you know, a difficult point to talk about, but I think acuity wise, we are seeing different patients coming in. We are seeing more patients come in that have different needs that may not need admission. And there is a point, particularly at Huddersfield site, of keeping people in the department for the frailty service. So we have a frailty same-day emergency care service that runs 7 days a week. And there is a bit of a pattern of, okay, if somebody comes in at say midnight, 1 o'clock in the morning, and keeping those patients in the department to be then seen by the frailty team in the morning. So we're looking at that, and what we're trying to do is use some case studies about whether those patients can actually be discharged and brought back to see the frailty team if appropriate the next day, or actually be seen out by the urgent community response team instead. So I think sometimes what we do is we create these services and then we think, oh, right, we're going to keep the patients in for them, but forgetting that there are community options to support those services as well. So, you know, there's different things we're looking at, and that reset week, we're going to try and change some of that around the frailty, and there is the same around therapy. We keep people in A&E for therapy in the morning. So we're going to try and change some of the narrative around that.
Okay, thank you. Very helpful.
I think some of this is not just our performance, I think, is the point you're making. And I guess through both the Kirklees partnership and the Calderdale Cares partnership, there's big opportunities for maybe sort of some of those broader discussions around some of those other services, not just the ones that we run, but that others run. I think also, I guess my observation is it's a bit atypical at the moment. So we have our performance measures and we look at our benchmarks and all of those sort of things, but it's a sort of a bit atypical because we're sort of still operating in this post-COVID period. So the benchmarking can be quite challenging. Sometimes it's we're not as bad as everybody else, but it still might not be good enough for us. And it's about resetting a lot of that stuff. I think, and there's almost like that's the same for everybody, and so we'd probably just have to be really careful, I think, in terms of some of that benchmarking at the moment, that we're we probably need the world to settle down a little bit first, perhaps. I don't know, it's just an observation. But I guess there's nothing in this performance report that we should be overly anxious about today, that we're not already cited on and aware of, is what I take from that report. So thank you for that. Now, Karen, during there you were doing quite a lot of thumbing ups, and I didn't know whether you were trying to put your hand up and couldn't, and that was your best way of indicating, but I thought I'd better check. You were just experimenting with the reaction button, weren't you? Oh dear, that's fine. Right. So at this point, we move on to our board assurance framework. And I always think at this point in a board meeting, there should be nothing new in here. It should be, because if our agenda's been right and if the discussions we've had have been right, then everything should be reflected and recognised in our board assurance framework. And it's always a right good test. So let's see if we pass that test. And I'll hand over to Andrea.
Thanks for that, Helen. Yes, I think there's no surprises in this. So this is the first update of the board assurance framework for this year, and thanks to all the directors who have undertaken those updates. Usually we would have had a review of this by the Audit and Risk Committee, but the sequence of meetings means that it will be slightly after the board, so that scrutiny will still happen at the end of July in the Audit and Risk Committee. So the paper describes the breakdown of the risks by our strategic objectives, with the keeping the base safe having the highest number of risks and the highest number of red risks. I think as you reflect on the discussion today, that feels right. During the last round of updates, we've identified a new risk around health and well-being, and we've heard earlier how much workforce is our key area of risk, and clearly the well-being of our colleagues is key to that. So that is a new risk that is scored at 12 and is detailed in the papers, and that will be overseen by the Workforce Committee. In terms of other movements of risks, I'll take the paper as read, but we've had 4 risks with a reduced score, and that reflects some work that's taken to where people have had space to implement the actions to mitigate the risk. So that's good to see some downward movement there. And we've had an increase in one risk, which is the commercial growth risk, which is a risk that had reached its target score. We'd kept on the risk on the board assurance framework because we anticipated it might increase, and the rationale for that is in the paper and is related largely to the Huddersfield Pharmaceutical Services and their commercial work. So I'll just pause there for any questions. So we're looking for the board to approve the new risk the updates to the risks and consider if there are any further risks. But as you've said, hopefully there's nothing that we're not aware of in terms of risks today. So I'll just pause there for questions.
Okay, Andy?
Yeah, me again. So just as kind of sitting on ARC and owning the process, I'll just say to kind of executive team in particular, I think we keep improving the BAF, which is great. So in terms of the quantity of updates through here and the quality of those updates, I think that's, you know, showing it's an active tool, which is great in these movements, which in the past it wouldn't have been as much. So I think I'm really pleased to see that. I think there's still just some little bits of tidying up, which we can pick up through ARC, Andrea, and just tidying up actions, fully align with gaps. And I wonder one of the risks, which is 520, whether it needs a bit of rephrasing and become more of a recovery focused risk. But again, we can take another look at that at the Audit and Risk Committee.
Okay, yeah, will do. Thank you.
Okay, thanks. And Karen?
Right, I'm happy to be completely wrong and everybody else disagrees with me on this one, but the climate change one, I was just a bit surprised at being reduced simply on the basis that we had a plan in place and approved and a green planning group in place. So I was a bit surprised that it had reduced on that basis. That was the explanation as I'd understood it, but I'm happy to be on my own with this one.
Stuart, I don't know if Stuart or Andy might wish to respond. I think there was a consensus that was appropriate, so perhaps Andy or Stuart could enlighten us a bit more on that.
I guess it gives you a control, but perhaps not an assurance.
So I guess all I would say, Karen, is it goes through, it has come through board on an annual basis and goes through Transformation Programme Board. There's a quarterly update. But I guess we would say the progress we've made. So if you looked at the detailed action plan behind the green plan, which has, I forget how many actions on it, 150, 160 actions, we've now cleared something like 60 or 70% of those. So we've made a lot of progress against the detail actions. We haven't just got a plan, you're right, we've written a nice plan. We've got a bunch of detailed actions behind it, and we've delivered on a good part of those already, and tangibly so, and we can evidence it. So that's why I think it's right to bring the risk score down.
Right, okay, I understand. Right, okay, thank you.
Okay, good challenge though, thank you. Was your hand, oh yeah, Andy's hand's gone down now, so that was in response to that particular one. So with those couple of points discussed, we're happy to approve the additional risk around colleague health and wellbeing, approve the updates, note the movements, and nobody else is flagging up anything that we would consider to be a risk to the achievement of our strategic objectives at this point. Yeah, that's good. Okay, thank you. So we're still with Andrea now as we get into a set of sort of governance changes that we need to make. And I did have to get some clarity from her about our job versus the Council of Governors job here, because I was aware that I'd sat in on observed a meeting of the Council of Governors Noms and Rems Committee that had this discussion, and I know there's a Council of Governors meeting next week that's also going to talk about this. So maybe if you could just explain our job here. And then we know what it is we're doing, particularly around those constitution and appointment of deputy chair and synod, and also we note Karen's declaration of earlier interest here.
Yeah, thank you, Helen. So the two items that involve the governors are items A and B. Item A is a proposed amendment to the trust constitution, and that requires both the board of directors and the council of governors to approve it. And I'll explain with the synod paper the sequence of events for that. So just starting with the proposed amendment to the trust constitution, this has been considered by the Council of Governors and has been supported by it. So it's brought here for the final stage of approval. And the detail is given in the paper, but following discussion of succession plans at both of our nominations and remuneration committees, there's been a requirement to increase the number of one executive director and one non-executive director in line with our constitution, and those roles will support some of the areas of work that we've identified earlier today, such as the partnership working and the health inequalities. So because our constitution currently only allows for 6 exec directors and 7 non-exec directors, we need to formally increase the numbers by 1 of each in that constitution the Noms and Remuneration Committee of the Council of Governors considered this, and the Council of Governors itself approved the change. So we're bringing it here to the board for approval. So I'll just pause there on that point for any questions.
Okay, are people happy to approve this? It's presented. Yeah.
Thank you. And we will change the same information in the standing orders so it's all consistent as well. So thank you for that. So moving on to the appointment of the Deputy Chair and Senior Independent Non-Executive Director. Many thanks to Richard Hopkin for having occupied this role for us. And with Richard's tenure coming to an end at the end of August, we've considered what the future arrangements will be. And it is proposed that Karen takes on the role of Deputy Chair and Senior Independent Non-Exec Director. The role is briefly outlined in the paper. In terms of process, this is a Board of Director decision, which we then ask the Council of Governors to ratify. So the board need to consider this first before us taking it into the Council of Governors for ratification, which we will do on the 14th of July. So I'll just pause there for questions for the approval of Karen as Synod and Deputy Chair.
Happy to approve that. Yeah,
thank you.
Marvellous. Thank
you. The use of the trust seal is an item for noting, just 2 instances there over the last period since January. And the board meeting dates proposed for next year are included, as well as the work plan. I think, as we've alluded to today, we have a new chair and a new director of corporate affairs, so we will possibly be reviewing that over the next few months, and we'll bring back any changes here to that following those discussions.
I thought you were going to say we have a new chair and a new director of corporate affairs that won't be able to help themselves and to fiddle around with it.
Not at all. No, it's important we evolve these things going forward, isn't it?
Yeah, I think as long as we get the dates in the diary, I think that's what's important. Then people have got good advance notice of those dates for next year, and then we'll develop the work plan as we go ahead. Okay, well, thank you very much for that, Andrea. That's great. So we've just got the review of our board subcommittees. We've got the specific piece around the terms of reference for the workforce subcommittee, and then we've got our subcommittee reports. So if we do the terms of reference change, I think that's you, Karen.
Yeah, it's very straightforward. It's to add Vicky's role as Director of Corporate Affairs into our terms of reference.
And are we happy to approve that? Great.
Thank you.
Thank you very much. Now I was going to suggest on 22 and 23 we take them together. Again, each of the committee chairs has had the opportunity throughout the agenda to sort of share what their committee has been doing in respect of items that we've had. It's also the time for the annual reports, which are all available in the review room. I'm just learning what that is. I keep forgetting what this review room is. So I don't know if I just take you each in turn, and if you want to highlight anything that your committee has done and anything on your annual report that's not been picked up during the course of the meeting, and then I'll start, if that's okay. I'll start with Richard.
Okay, thanks, Helen. We had a latest Finance and Performance Committee meeting earlier this week, as has been referred to on a number of occasions. To be honest, the key points that are already included in my chair's highlights report are largely the same ones coming out of that meeting. It hasn't fundamentally changed. As we've noted from Joe, the IPR performance came down slightly in the month, but the key issues are still the key issues, and the positives are largely still the positives. I should say that there isn't specific reference in that report to the deep dives that we've had and are ongoing. So we've done deep dives on areas such as stroke and fractured neck of femur, as well as on workforce, particularly around availability and absence. And we've got updates due on on all of those, frankly, over the coming months. And we did actually talk about, as a result of the discussion in the meeting this week, maybe having a deep dive into A&E, emergency department performance, to address some of those concerns that Joe's highlighted earlier. Beyond that, I don't think I need to comment any further at this stage, unless anybody's got any questions.
Okay, and nothing specific from your annual report? No.
No, I don't think there's anything particularly else to highlight. Helen.
Thank you. No hands going up, so we'll take that as read. Thank you very much for that update. And if I ask Denise next, again, if there's anything specific from your committee meeting, but also from your annual report.
Okay. So my chair's highlight report for the quality committee meetings in May and in June, and I think just to highlight a couple of things from those meetings, we received an update report regarding the split paediatric service and in terms of the development of the paediatric pathways on both HRI and CRH sites. And one of the things that came out of our discussions that it was felt that there was more work to be done just to review the kind of original escalation process for paediatric oversight of patients who are under the care of adult surgeons. So we've requested that work is that's reviewed and comes back to quality. And just for you, I think, Helen, that you know that on a monthly basis, maternity services and Ockenden, we have oversight at quality, so we do get a report at all of our monthly meetings. And one of the things that came out of the meeting in terms of the maternity transformation plan is we will continue to have quality committee oversight, and we will get regular progress reports on the work that's undertaken there. I think the other thing, just other two things to mention very briefly, is that in the June meeting, we reviewed the quality accounts for 2021-22, and they were approved. We've also asked an area of concern really was in relation to the learning disabilities mortality report, which showed a decline in care overall. So we've requested that plan comes back to us in terms of the work that's going to be undertaken in regards to this area. And then in terms of the annual report, I think it's quite straightforward. It summarises the activity and the work undertaken by the Quality Committee for the last year.
Thank you very much. Thank you, Denise. There's no hands going up, so I'll move to the final subcommittee report from Karen.
Yeah, I think the highlight reports, successive highlight reports have been a summary of what the committee has been involved in. And as Suzanne said much earlier around the people strategy, there has been a number of papers that we've had before we actually got to that point of looking at the strategy. For example, the recruitment strategy is well on its way to being finalised as well. We've had a number of deep dives, particularly around vacancies and turnover, and obviously looking at the age profile as well of the workforce, because we've discussed here our concern about having that ageing workforce. We've looked at freedom to speak up. We've also looked at leadership development and the progress that's been making alongside all the EDI activity as well as the wellbeing. So as a committee, we've been looking really very deeply into a lot of these areas, and we'll continue to do so.
Thank you.
That's all I have to say. I'm happy to take any questions.
That's great. So there's no hands going up. So just on behalf of the whole board, thank you for the work that the three of you have done on your committees. I know you all put in much more than is your sort of so-called time commitment into making these committees effective. And you clearly take your role as chair of those committees very, very seriously. So thank you very much. It provides good assurance to a board that you put a lot into there. Okay, so if we're okay, we will move on to the final item in our review room. It was was Stuart's report from CHS, and I didn't know if any Stuart wanted to highlight anything specific for the board's attention, or whether anybody had any questions on the back of that report.
I wasn't intending to highlight anything specific in the absence of Tim being here, but happy to take any questions.
Okay, thank you.
Thanks.
Again, no questions, no hands going up. Okay, so thank you very much. That brings us to the end of the public, the meeting in public. Our next meeting will be on Thursday, the 1st of September. And as I said, I'm hoping it's going to be in a boardroom somewhere, and that we can see each other. I just want to just give the governors who have attended today the opportunity, if they want at the end of the meeting, if there's anything they wanted to say in respect of any item. I understand you're all more than happy to stick your hand up at points during the meeting, because I was just slightly concerned as whether I'm supposed to specifically ask you, but I understand you'll do that if you need to do. But just one opportunity for you at the end, if there's anything you'd like to comment on, or anything you'd like to raise in respect of what you've heard today. Gina.
Hi, I think it's been great. I've really enjoyed it. A lot of this comes to quality, and obviously I sit alongside Denise and I observe those, and it's been great to see the process, how it all comes together. I'm really excited going forward, and the thought of getting into a boardroom with all of you, it just fills me with joy. So thank you for that.
Oh, that's lovely. Thank you. And Peter?
Thank you, Helen. I remain reassured that the hospital is being looked after well.
That's good, and that's what we seek to do, don't we? So and Christine.
Thank you for the offer, but no, it's just interesting to listen to everything that goes on. It puts things into perspective as we see a little bit in whatever committee we are on. It's very interesting to see it all put together in one meeting. Thank you. Good.
Thank you very much. Thank you all for your contributions, and for making my first board meeting as easy as I could do. And I'm sorry I didn't quite manage to land on the 12 o'clock deadline, but 11 minutes, it's not too bad, is it? Okay, so I think for those who then meet later, I think we go out and come back in on another link, do we? Yep, that's good. So if we give ourselves a few minutes and we come back in, what do we need? 5 minutes? And then we'll come back in on the other link. Thank you very much, everybody. Thank you. I can breathe a little sigh of relief now.
Thank you.